case is methotrexate toxicity, a case report. It is so I received a 70-year-old housewife resident of East Champaran district who presented to the emergency department of IGMS in great agony. Her chief complaints were fever since 5 days, unable to eat and drink since 5 days, oral ulcers in 5 days, skin rashes and ulceration maximum and over the buttock and the inguinal region since 2 days. So she was apparently asymptomatic. Then she developed fever, which was abrupt in onset, high-grade fever, partially relieved on medication, and she was having difficulty in food and drink ingestion, which was gradually progressive, burning pain on swallowing, while her appetite was intact. There were skin rashes, which were abrupt in onset, gradually progressive, and started from limbs. She was a known case of rheumatoid arthritis, diagnosed around 1 year back with remission on methotrexate, 7.5 milligram weekly, and DMARDs. Infrequent taking NSAIDs and steroid tablets from local pharmacy shops for painful episodes. Until recently, 1 week back, when she visited doctor who prescribed methotrexate 5 milligram weekly with folic acid tablet daily along with oral steroids. There were no other comorbidity or surgical history, no significant family history, no significant addiction, mixed diet. She was having a lower middle class according to modified Kupus-Swami-Stay. So in summarize, 70 years old lady, a housewife, normotensive, normodiabetic, who is known case of RA, diagnosed 1 year back, presented with high-grade fever, unable to drink since 5 days. She also complained of pain in all the small and large joint with morning stiffness, asymmetrical of more than 1 hour. Her general examination revealed pulse rate, which was 90 per minute, BP was in the normal range, temperature was febrile, SpO2 and room air. On general examination, there were skin rashes in the form of multiple petechiae and ecchymosis over the upper and the lower limbs, buttocks and the trunk. Mucosal bleed with crusting, an aphthous ulcer in mouth, and oral thrush. Pallor was present, no neck veins and glands noted, and bilateral lower limb edema was present. There was swelling in the bilateral upper and the lower joints with raised temperature and tenderness. Range of movement was restricted, and all the systemic examination were normal. In the dermatological examination, it revealed ulcerated erythematous to livid plaques of 1 to 2 centimeter diameter distributed predominantly in the inguinal region and the buttocks with less lesions. So this is the picture of her buttocks of the rash. In investigation, we found PBS was pancytopenia and anisopoikilocytosis. Retic count was 0.31 and serum methotrexate level was more than 0.3 millimole per liter. And these are the rest of the investigation, which were not significant. A biopsy of the representative skin lesion revealed ortho hyperkeratosis, vacuolization, and apoptotic keratinocyte in the stratum basale. It also had scanty lymphocytic perivascular infiltrates in the dermis. Diagnosis was RA with acute flare, pancytopenia with febrile severe neutropenia, severe thrombocytopenic purpura, oral esophageal candidiasis, and AKI. So we started with IV hydration, 4-unit platelet transfusion. We gave her injection filgrastim, 300 micrograms subcutaneous, then continued for 3 days until her WBC level became normalized. We also gave a rescue therapy of infusion, leucovorin 50 mg 6 hourly for 2 days. And antibiotics were modified on follow-up days due to rise in serum creatinine. These are the rest of the investigation. As you can see, on the day 5th, her WBC count came down to normal, and before discharge, it was already normal. So outcome was under intensive local and systemic therapy, the lesion healed gradually, first on the trunk and the back, slowly on the buttocks and inguinal. After 6 days of treatment, there was a complete normalization in the blood count, and most of the ulcerations were re-epithelialized after 8 days. So low dose methotrexate in RA rarely produces toxicity, and almost most of the such cases occur due to failure to adhere to the recommended guidelines. The risk of toxicity is greater if additional methotrexate is administered sooner than the usual scheduled weekly dose. In this case, it was a self-administration of the higher consecutive dose for 2 days, which acted as a precipitating factor. This is the final image of the after the stabilization therapy. So in summary, pancytopenia due to methotrexate is attributed to patient with renal dysfunction, presence of infection, folic acid deficiency, and concomitant use of some drugs. The probable cause of myelosuppression in this case could be advanced age, concomitant use of NSAIDs, and inadvertent use of methotrexate. So take home message, it is must to monitor self-administration of such kind of drugs, and pre-treatment investigation should be made mandatory, and co-administration of drugs like NSAID should be judicious. Thank you.
Thank you. This methotrexate was given for rheumatoid arthritis,
Right.
DMARD.
Right.
What are the other drugs for disease-modifying anti-rheumatic drugs?
Sir, it's sulfasalazine, hydroxychloroquine, leflunomide. Earlier, gold salts were also used.
Do you think 6 days is enough for the recovery? Your patient recovered within 6 days.
Sir, we started with the leucovorin rescue on the day itself when the patient came. So I think the patient recovered well because we also gave her topical ointments, and that in that steroids were present. So maybe, sir, that made the wounds heal faster.
You can.
Yes, sir.
Dipencilamine is also used as DMARD?
I'm not aware, sir.
Okay.
Is there any alternative drug for treating rheumatoid arthritis better than this, having less toxicity?
I think, sir, hydroxychloroquine and sulfasalazine can be used, and it produces better outcomes if in such cases.
Okay, thank you.
Thank you, sir.
Thank you so
Thank you,
much.
sir.
With this, I would like to request our next speaker, Dr. Nimisha Bajaj, to please join us on the dais.
Good afternoon, everyone. My case is a rare case of juvenile dermatomyositis, sign dermatitis with polyneuropathy. Dermatomyositis is an autoimmune idiopathic inflammatory myopathy characterized by symmetrical, prominent proximal muscle involvement and is known to have multiple cutaneous manifestations. Based on clinical presentation, dermatomyositis is classified as classical, having both skin and muscle manifestations, amyopathic, which involves skin manifestation without any muscular involvement, and dermatomyositis sign dermatitis with muscular involvement, but there are no skin rashes. In this report, we describe a patient with an atypical presentation of juvenile dermatomyositis, sign dermatitis, complicated by neuromyositis, with presence of novel myositis-specific autoantibody NXP2. A 17-year-old female presented with complaints of generalized body ache and progressive muscle weakness for last 2 months, making her activities of daily living like combing hair, standing up and down, and taking a staircase difficult, associated with dysphagia and nasal regurgitation for last 10 days. She also complained of gradually progressive generalized body swelling and oral ulcers for the last 3 days. On examination, patient was bedridden, conscious-oriented, with extensive swelling of whole body, with diffuse edema in neck area, making her mouth opening difficult. Decreased muscle power was noted, muscle power was 1/5. Oral examination revealed diffuse swelling of lips with multiple ulcers on the inner side of lips. Deep tendon reflexes were diminished. Sensory examination were normal, with normal bladder and bowel movement. Rest systemic examination were normal. No skin changes were noted. Laboratory report shows hemoglobin of 9.7 gram per deciliter, total count of 34,000, of which neutrophil was 83%, creatinine kinase was 11,463 units per liter, LDH was 1618 unit per liter, AST and ALT was elevated, and CRP and ESR was mildly elevated. ANA titers were positive. Viral markers was negative, and at that time CSF fluid was sent. The rest of the routine investigations were within normal limit. Patient was started on broad spectrum antibiotics and other supportive treatments. MRI brain with screening of whole spine was performed, which showed no significant finding. Nerve conduction studies showed sensory motor axonal neuropathy of all 4 limbs. Electromyography shows signs of myopathic potential with spontaneous activity. Myositis-specific autoantibody panel resulted positivity for NXP2. Rest of the antibodies were negative. ENA profile was not significant, as the CSF finding was also not significant. A 5-day course of methylprednisolone 1 gram daily was started. The swelling partially subsided, but there was no improvement in muscle part. Instead, patient's condition deteriorated with new onset cough with expectoration, decreasing single breath count and falling saturation. She was put in ICU and was started with non-invasive ventilation. Blood culture was sent and it was positive for Mercos. Sputum culture was positive for Acinetobacter baumannii. CECT thorax was revealed ill-defined consolidation with air bronchogram involving right lower lobe suggestive of aspiration pneumonia. Antibiotics were switched according to culture and sensitivity reports. She was then put on oral prednisone 1 mg per kg daily along with mycophenolate mofetil 500 mg twice daily. Her condition gradually improved with power of 3/5 in all the 4 limbs and adequate mouth opening, but difficulty in deglutition still persisted, so rice tube feeding was continued. Repeat laboratory reports showed total count of 9700, and their AST, ALT levels were also in the improving range. Supportive treatment was continued and patient was stepped down from ICU. Physiotherapy of limbs and chest was regularly performed. Pain and swelling subsided. Patient was discharged after 22 days of hospital stay on oral prednisone 40 mg daily along with mycophenolate mofetil 500 mg twice daily with adult supportive treatment and physiotherapy. Feeding with rice tube was continued. She is in regular follow-up in our OPD with excellent improvement. Muscle power in all the 4 limbs at present is 4/5, but still having some difficulty getting up from chair or combing hair and needs some support for that. In her last follow-up, she was able to take oral feeds without any difficulty. Despite the lack of classic skin rash, the severe diffuse subcutaneous and soft tissue swelling should raise a suspicion for edematous myositis, which is mostly dermatomyositis. Positive NXP2 antibody, EMG finding a lack of skin rash helps to make the diagnosis of JDM, sign dermatitis, which was complicated by neuromyositis as evident by NS finding. Juvenile dermatomyositis are rare childhood chronic rheumatic disease among which sign dermatitis is seldom described because of its rarity, making the diagnosis more challenging. Although typical skin manifestations are the pathognomic signs that suggest dermatomyositis, we should not exclude the possibility of dermatomyositis sign dermatitis. Thank you.
What do you think? What will be the prognosis of this case?
Sir, the prognosis of dermatomyositis is good in case if it occurs in early age, as in this case, and if we start the treatment early, its prognosis is good, sir.
We have to continue the treatment for long.
Yes, sir.
To prevent any further relapse or any
Yes, sir.
recurrence.
We taper the dose according to the clinical improvement of the patient.
Did she have any cardiac problem?
No, sir. No cardiac manifestation.
ECG was normal?
Yes, sir. ECG
no
and
conduction defect?
No, sir. ECG and echo both was done and it was normal.
Okay. Okay, thank you.
Sir.
Thank you so much. With this, I would like to request our next speaker, Dr. Nusrat Jahan, to please join us on the dais.
Good afternoon, everyone. I am Nusrat, here to present on the topic prognostic significance of serum albumin and serum cholesterol in acute decompensated heart failure patient. Introduction. More than 20 million people are affected with heart failure with the prevalence of 2% which rises with age, and the prevalence is more than 65 years of age is 6 to 10%. Serum albumin and serum total cholesterol are two simple and inexpensive markers of malnutrition inflammation syndrome. Recent researches emphasizes the importance of serum albumin and total cholesterol in identification of patient with acute decompensated heart failure patient. Although hypoalbuminemia occurs in 1/3 of patients with systolic heart failure and has been demonstrated to be independently associated with increased risk of death, little is known about the relationship between hypoalbuminemia and outcome in heart failure. Hypercholesterolemia is a risk factor for development of coronary artery disease. However, several reports have suggested that low serum cholesterol is associated with worse prognosis in patients with congestive heart failure. So serum cholesterol is a double-edged sword when it is very low or is very high, associated with inferior outcome in heart failure patient. Aim is to assess the usefulness of serum albumin and total cholesterol for the prediction of hospital mortality and need for hospitalization in acute heart failure patient. Methods. In this descriptive study, 50 patients admitted with acute decompensated heart failure were selected, and duration of the study was 6 months. Inclusion criteria was patient with acute decompensated heart failure who had symptoms of heart failure and who responded favorably to IV furosemide therapy. Exclusion criteria: acute coronary syndrome patient and patient with permanent pacemaker, severe arrhythmias, liver cirrhosis, end-stage renal disease, and nephrotic syndrome. Result: there was a strong positive correlation between serum albumin, serum cholesterol, and ejection fraction, and there was a strong negative correlation between serum albumin level and age, heart, and duration of hospital stay. In this chart, this shows total 50 patient was selected, and 70% of patient was having hypoalbuminemia, while 16% of patient was having hypocholesterolemia. The median duration of stay was around 6 days and 18% was accumulated to the illness. Mortality was high among subjects with hypoalbuminemia and hypocholesterolemia than subjects without these conditions. Mean duration of hospital stay in patients having hypocholesterolemia and hypoalbuminemia were more than patients who were having normal albumin and normal cholesterol level. Discussion: acute heart failure syndrome carries disturbing hospital mortality rates which increases with advancing age and illness. Mortality was high among subjects with hypoalbuminemia and hypocholesterolemia than subjects with normal albumin and cholesterol. Thus, they can be used as a prognostic indicators for predicting the in-hospital mortality rate and poor outcomes. There was a positive linear correlation between serum albumin level and serum cholesterol level, and there was strong negative linear correlation between serum albumin level and age and heart rate of the patient and hospital stay of the patient. The in-hospital mortality rate of heart failure is 18%. Conclusion: we address the clinical relevance of serum albumin and serum total cholesterol on top of the usual prognostic variables, because abnormal concentration of these two biomarkers of malnutrition inflammation syndrome are common in elderly patient and patient with heart failure and indicate poor prognosis. Thank you.
You talked about acute heart failure.
Yes, sir.
Can you tell us some causes for acute heart failure?
Acute coronary syndrome, the myocardial infarction.
Acute coronary syndrome.
Myocardial infarction.
You mean acute cardiac syndrome or myocardial infarction?
Myocardial infarction.
You take out the acute coronary syndrome.
Yes, sir.
Acute coronary syndrome includes how many things?
It includes cardiac biomarker changes and
One is myocardial infarction. Before that,
chest pain and
unstable angina.
unstable angina.
Okay, and chronic stable angina is another.
Yes, sir.
So there are two things in
Yes,
acute
sir.
heart ACS.
Yes, sir.
The unstable angina going to myocardial infarction.
Yes, sir.
So a person comes with acute myocardial infarction,
Yes, sir.
and your study was for 6 days.
Yes, sir.
So what do you
My
think?
study, sir, actually my study was for 6 days, and it included the patient was who were already having heart failure.
No, you talked about acute heart failure.
Yes, sir. Yes, sir. Decompensated heart failure.
Okay.
Okay.
Heart failure is
Yes, sir.
decompensated.
Yes, sir.
No problem.
Yes, sir.
So you name one cause of acute heart failure, that is myocardial infarction.
Yes,
Acute myocardial infarction,
Yes,
right?
sir.
So that acute myocardial infarction was associated with hypoalbuminemia and hypocholesterolemia to begin with, or it developed with acute heart failure?
It developed with heart failure.
Why? What was the cause? You have already excluded other causes of hypoalbuminemia.
In older ages, there is more chances of malnutrition and decreased intake of and decreased absorption of albumin.
Go ahead.
And there is decreased absorption of various micronutrients and albumin. Yes, sir.
Hyperlipidemia causes some manifestation over the face. What is that?
Sir,
Around the eye.
it's xanthelasma.
Xanthelasma, okay.
How many types of xanthal histamine? How many types of xanthal histamine? Okay, there are two types, cholesterolemic and non-cholesterolemic.
Thank you. Thank you so much.
Sure.
Moving ahead, I would like to request our next speaker, Dr. Kisle Sharma, to please join us on the dais. And meanwhile, I would like to announce the next 3 names of the speakers so that they can be ready. Next is Dr. Nidhi Kumari, Dr. Mohammad Muzammil, and Dr. Varsha Kumari.
Good afternoon, everyone. My name is Dr. Kishle. I am Junior Resident, Department of Medicine, RIMS Ranchi, and my case presentation will be on the topic dengue fever complicated with Guillain-Barré syndrome. Starting with a brief introduction, dengue, as we all know, is caused by dengue virus, which has 4 serotypes, 1, 2, 4, and caused by Aedes mosquito. Excuse me, it's not. Slide bar nahi raha. caused by dengue virus, which has 4 serotypes, 1 to 4, and the vector is Aedes mosquito. Dengue fever is a major global public health challenge with 400 million infections per year and being endemic in more than 100 countries worldwide. It usually presents with fever and myalgia, with neurological manifestations being a rare complication. Incidence of neurological complications in dengue ranges from 0.5 to 6% and includes encephalitis, myelitis, seizures, GBS, and few more. Guillain-Barré syndrome is an acute, frequently severe, fulminating polyradiculoneuropathy that is autoimmune in nature. Approximately 70% cases occurs 1 to 3 weeks after an acute infectious process, usually respiratory or gastrointestinal, and some of the organisms which are implicated include Campylobacter jejuni, human herpes virus, CMV, Epstein-Barr virus, Mycoplasma. GBS, though an uncommon neurological sequelae of dengue fever, but the neurological picture induced by the dengue virus is similar to GBS caused by other infections. This is an article from a Neurology India journal where we can see Guillain-Barré syndrome affecting the roots and also the nerves, apart from some other complications of dengue virus. Our case, a 47-year-old male patient, resident of Jharkhand, was admitted with chief complaints of generalized body ache, fever, and nausea of 7 days duration. At presentation, his complete blood cell count showed thrombocytopenia, platelet count was 86,000, and his dengue IgM antibody was positive. During the course of admission, he started complaining of pain and weakness in bilateral lower limbs, which gradually progressed to involve bilateral upper limbs as well. He was unable to walk or get up from lying down or sitting position. However, he did not show any signs of bladder or bowel involvement, nor were he having any breathing difficulty. There was no history of any recent respiratory diarrheal illness or any recent vaccinations. He also did not have any significant comorbidities. On examination, CNS examination, there was hypotonia of bilateral lower limbs with power grade 1 in both lower limbs and grade 3 in both upper limbs. The lower limb tendon reflexes were absent with reinforcement and his upper limb reflexes were diminished. All his sensory modalities were intact. The patient had also developed element type of facial palsy and his gag reflex was preserved. So we made a provisional diagnosis of Guillain-Barré syndrome. Nerve conduction studies revealed prolonged latencies of F wave, and ulnar CMAPS compound muscle axon potential also showed prolonged latencies. A cerebrospinal fluid study was done which showed albuminocytological dissociation with CSF protein being 247 mg/% and cells 29. CPK NAC levels and electrolytes were also done to rule out other differentials of Guillain-Barré syndrome. The patient was then started on IVIG, intravenous immunoglobulin, 0.4 gram per kg per day for a duration of 5 days, and he was also simultaneously put on physiotherapy. The patient started showing significant improvement in his weakness from day 4 to 5 of therapy, and by the time of discharge, he was able to walk with the support of a stick. GBS, it is suggested that the clinical manifestations of GBS are a result of cell-mediated immunological response to non-self antigens that misdirects to host nervous tissue. This is known as molecular mimicry. This is a pathogenesis showing demyelination of nerve cells where we can see anti-myelin IgG antibodies which targets the myelin sheath via the help of membrane attack complex, complement pathway, and activation of macrophages. So conclusion, this case report shows that GBS, though an uncommon sequelae to the dengue fever, its possibilities should always be kept in mind in an endemic zone in patients presenting with acute flaccid paralysis. Thank you.
So your diagnosis for LGP was clinical as well as CSF examination, yes, with a previous history of dengue.
Yes, sir.
Right. So you found there is albuminocytological dissociation. Name few other causes of albuminocytological dissociation.
It can occur in, sir, viral myelitis as well, or sir?
Other causes of albuminocytological dissociation.
Sorry, sir, I'm not aware of this. I could not remember this right now, sir.
Acoustic neuroma,
Acoustic neuroma.
Freund syndrome, and this. Okay. Now you talked about that the bladder was normal.
Yes, sir.
At times we find that there is bladder retention. What is the cause for that? You are right.
In 15% cases, we do find bladder involvement.
Your abdominal muscles are weak, that's why it is.
Yes.
retention is there. Sir.
Thank you, sir.
Moving next, I would like to request Dr. Nidhi Kumari to please join us on the dais.
Good afternoon. I am Dr. Nidhi Kumari from MJ Medical College. My topic is Guillain-Barré syndrome following primary varicella infection, a case report and review of literature. 23-year-old male unvaccinated for varicella zoster presented with history of vesicular rash and crusting for 2 weeks following rash in 3 prior family members. He complained of generalized weakness, dysphagia, pain in whole body, and he was unable to walk for 3 days. The weakness first began in the proximal part of the bilateral lower limbs and then progressed distally to involve the entire lower limb within 2 days. Simultaneously, he developed weakness in bilateral upper limbs. The weakness was accompanied by dysphagia, which improved in the next 3 to 4 days. On examination, he was alert, conscious, oriented to time, place, and person. He was afebrile, normotensive, and had tachycardia with 106 beats per minute. Respiratory rate was 18 breaths per minute. He had multiple vesicles and crusted lesions scattered on whole body. He had a flaccid symmetrical quadriparesis, MRC grade 2/5 proximally, and distally it was 3/5 in all the 4 limbs. All deep tendon reflexes and both plantar responses were absent. Appreciation of vibration, joint position, and pinprick was bilaterally diminished. Examination of other systems showed no abnormality. On investigation, urea, electrolytes, LFTs, CBCs were normal. Chest X-ray and CE MRI of brain and spinal cord also showed no abnormality. The CSF was clear, colorless, and sterile on culture. Total protein was 65.4 mg% and glucose was 72 mg%. Nerve conduction study confirmed a severe generalized demyelinating peripheral neuropathy with conduction velocities all below 25 meters per second. Prolonged distal latencies, absent snap, and prolonged F waves in bilateral median, ulnar, peroneal, and tibial nerves was found. Patient management. My patient was managed conservatively with a close watch on vitals as he was unable to arrange immunoglobulin or plasmapheresis, and the same is not available at our institute. He showed improvement in 4 weeks and was almost back to normal in 8 weeks. The reflexes also were back to normal within 12 weeks. He did not need any ventilatory support. Introduction. GBS is an acute immune-mediated polyradiculopathy that encompasses many clinical variants and divergent pathogenic mechanisms. Preceding infections are predominant trigger of GBS. Varicella zoster virus may trigger GBS, but this is rare and almost always in the context of reactivation disease from latent shingles. My patient showed typical clinical features of GBS, which was areflexia, symmetrical progressive weakness of the limbs, paresthesia, and numbness in association with generalized body ache, and no bladder and bowel involvement. However, the CSF studies did not show albuminocytological dissociation at week 1 and was also repeated on week 3. Discussion. Varicella zoster virus causes 2 distinct clinical entities, which is varicella, that is chickenpox, and herpes zoster, which is shingles. GBS following varicella infection is rare. Majority cases were associated with varicella zoster, which is shingles. GBS associated with primary varicella infection or chickenpox is even rarer. Since the first description in 1924, there has been only 39 cases reported, out of which 31 had shingles, and only 8 cases had primary varicella, and out of which only 1 has been reported to be an adult. A review of the reported cases revealed that eruptions of varicella can occur in any part of the body, and GBS follows acutely or subacutely, the latent period ranging from 2 weeks to 2 months. All the reported cases had quadriparesis except 1 case which has paraparesis. The pathogenesis of GBS following varicella is still not well understood. This case suggests that primary varicella zoster may sometimes be a sufficient stimulus to drive antibody formation and to precipitate severe clinical symptomatology. These are the references. Thank you.
Clinical diagnosis was GB.
Yes.
What are the variants of GB?
Sir, majority we have two variants, which is demyelinating form and the axonal forms. The demyelinating form is the most common, which is AIDP, acute inflammatory demyelinating polyneuropathy, and the axonal forms which are prevalent in Asia are Aman and Amsan. Also there is, yes sir? Also there is Miller-Fisher syndrome, and we have autonomic variety also.
The albuminocytal dissociation was present in this case?
No sir, albuminocytological variation was not present in this case because the cell count was normal as well as the protein count was also 65 only.
Okay.
Thank you sir.
GB syndrome is a neuropathy or radiculopathy?
Yes sir?
Neuropathy or radiculopathy?
Polyradiculopathy sir.
What is the difference between the two?
Sir, in radiculopathy we can have sensory symptom, root involvement is there, so we can have sensory as well as motor involvement, whereas in case of neuropathy, polyneuropathy, we will have involvement of the particular nerve root, dermatome only.
Radiculopathy from center to periphery. And neuropathy from periphery to center.
Thank you.
Thank you so much. With this, I would like to request our next speaker, Dr. Mohammad Muzammil, to please join us on the dais.
Good afternoon, everyone. Myself, Dr. Mohammad Muzammil, Junior Resident Medicine from Integral University, Lucknow. My paper presentation on a study of correlation of neutrophil lymphocyte ratio, platelet lymphocyte ratio, lymphocyte monocyte ratio with disease activity in patient of rheumatoid arthritis. Introduction: rheumatoid arthritis is a chronic inflammatory disease characterized by infiltration of synovium with neutrophils, macrophages, T cells, B cells, and dendritic cells, and progressive destruction of cartilage and bone, resulting in significant morbidity and shortened life expectancy. We aim to find out the correlationship of neutrophil lymphocyte ratio, platelet lymphocyte ratio, lymphocyte monocyte ratio with disease activity in patients of rheumatoid arthritis. Aims and objective: aim to find correlation of neutrophil lymphocyte ratio, platelet lymphocyte ratio, lymphocyte monocyte ratio with disease activity in patients of rheumatoid arthritis, and the objective to assess the correlationship of neutrophil lymphocyte ratio with disease activity in RA patient, to assess correlationship of platelet lymphocyte ratio with disease activity in RA patient, to assess correlationship of lymphocyte monocyte ratio with disease activity in RA patients. So methodology: in this prospective observational study, total 17 patients of rheumatoid arthritis were enrolled. All patients underwent comprehensive clinical demographic evaluation. Disease activity was assessed at various follow-up using DAS-28 score and WES score following the criteria set by EULAR, and CBC, CRP and ESR tests were done. So the observation: a statistically significant difference in the NLR and PLR between the different gender group, while LMR saw no significant difference. So according to ROC curve, the neutrophil lymphocyte ratio sensitivity is 32%, specificity is 77%, and platelet lymphocyte ratio sensitivity is 58%, and specificity is 64%. And ESR sensitivity is 68%, and specificity is 92%. CRP 77% sensitivity and specificity 92%. However, based on the ROC curve, NLR ratio and PLR ratio exhibited lower diagnostic accuracy compared to ESR in distinguishing inactive RA from active RA patient due to their lower sensitivity and specificity. So weak positive correlation were observed between the disease activity score and traditional inflammatory markers ESR and CRP with NLR and PLR. Combining the NLR or PLR did not significantly enhance the diagnostic value of ESR and CRP in discerning the disease activity in RA patient. So conclusion: the NLR, PLR and LMR ratio may not be useful independent diagnostic or complementary marker for disease activity in RA patient. However, the study is still going on. Drawing definition conclusion at this stage might be premature.
Studying in rheumatoid arthritis.
Yes, sir.
You understand my question and respond properly. What are the extra article manifestation of rheumatoid arthritis?
Extra article, there is pericarditis and lung involvement, peripheral.
You will name them. Lung involvement, what are those? cardiac involvement, what are those?
Pericarditis,
Like one.
pleural effusion,
You told only one in cardiac. Then pleural effusion, okay?
peripheral neuropathy,
Okay.
and
Something important in lung and heart. Very important.
syndrome.
Valvular lesions caused by rheumatoid arthritis. They are very important.
Sir, not aware about this. Right?
कार्डियक में कुछ बताओगे?
Uh,
और बताओ?
pericarditis.
एक बता ही रहे।
Yes.
और बताओ? कुछ कंडक्शन डिफेक्ट वगैरह बताओ? कुछ लीजन, valvular lesion बताओ? Tell us some valvular lesion specific of rheumatoid arthritis.
Sir, sorry, sir, not aware about.
What are the differential diagnosis of aortic incompetence?
Differential diagnosis for?
Aortic incompetence, aortic regurgitation, different causes.
Okay. Aortic rheumatic heart disease
Yes.
and aortic regurgitation, rheumatic.
ये भी होता है. Marfan syndrome,
Okay.
rheumatoid arthritis,
Okay, sir.
rheumatic heart disease.
Okay.
Okay, go. Thank you.
sir.
Hello. Thank you so much. With this, I would like to request our next speaker, Dr. Varsha Kumari. Meanwhile, I would like to announce the next three speakers' names. Dr. Vinay Kumar Verma, Dr. Akash Sharma, and Dr. Animesh Paul.
Good morning, sir. I am Varsha Kumari from PMCH Patna, and I'll be discussing cardiac amyloidosis, a rare case report with intrahepatic cholestasis. Sir, 73-year-old female presented to our department with dyspnea on exertion, NIHA class 3 since last 6 months, pedal edema since last 4 months, abdominal distension since last 2 months, and yellowish discoloration of sclera since last 2 days. Sir, on clinical examination, pedal edema. This is not working. Sir, on clinical examination, icterus was present, pedal edema was seen, ascites was present. Other system examinations were absolutely normal. As a part of our routine investigation, sir, blood investigations revealed conjugated hyperbilirubinemia with hypoalbuminemia with reversal of albumin globulin ratio of 0.7. SGOT and SGPT were absolutely normal, sir, and her serum creat was also deranged. So we went ahead with the ECG, and so ECG was showing low voltage complexes in all the limb leads and precordial leads with QS pattern in both inferior and precordial leads, simulating pseudo-infarction pattern. By looking at the ECG, we were suspecting some form of regional wall motion abnormality on echo, but when we went ahead with the echo, to our surprise, sir, there was no regional wall motion abnormality, and she had absolutely preserved ejection fraction. The echo is showing the biventricular hypertrophy with septal thickening. The ventricular wall thickness is also increased. Interatrial septum is also thickened. Biatrial enlargement is also there. On M mode view, sir, interventricular septum depth was about 1.7 centimeter, which is not normal. The normal thickness is less than 1 centimeter. With this echo, sir, with this echo, we were surprised to know that despite this amount of hypertrophy, patient was having no regional wall motion abnormality, and in spite of this hypertrophy, only QS complexes were seen. Sokolov criteria for hypertrophy was not seen in the ECG. We went ahead with Doppler, sir. We performed 2 Dopplers. Pulse Doppler and tissue Doppler was done. On pulse Doppler, sir, flow across the mitral valve was measured. We have 2 parameters, E and A. Normally, the flow across the mitral wall happens in 3 phases: the rapid filling stage, the diastasis, and the atrial contraction phase. So rapid filling in normal, like in me, it is like rapid filling has the highest peak because maximum of the blood flow is flowing through the mitral valve during the rapid filling stage. During diastasis, a lot of blood is not going, so we don't have a peak. We have two peaks there. First peak is denoting rapid filling peak, and the second peak is denoting atrial contraction peak. In normal individuals, sir, E has to be, the peak of the E has to be more than A, but in my patient, as we can see, both the peaks have been equalized. Or at some point, you can also see the E is less than the capital A. So with this pulse Doppler, sir, we came to a conclusion that patient has restrictive physiology with diastolic failure. We also went ahead with tissue Doppler, sir, where we measured the annular movement, mitral valve annular movement, and to our surprise, sir, we calculated the E by E prime ratio, and it came out to be 24. So E by E prime ratio is normally less than 14, and if it is more than 15, it is classical of diastolic heart failure, sir. With all this ECG and echo findings, sir, we were suspecting amyloidosis in patient, the classical ECG and echo pattern. We also requested one of our colleagues to perform global longitudinal strain imaging, and it was showing cherry red appearance. Cherry red appearance is the longitudinal strain in the apical region is preserved in amyloidosis, and all the walls and ventricle septum longitudinal strain is decreased. With suspicion in mind, sir, we went ahead with serum electrophoresis. We got 1M spike, which was suggestive of gamma globulin discrete protein. We got one discrete band in gamma globulin region, suggesting monoclonal gammopathy. We went ahead with rectal biopsy with stain positive for Congo red, and so we came to a conclusion that patient had cardiac amyloidosis secondary to multiple myeloma. Thank you, sir. So this was my last slide. Amyloidosis, sir. Amyloidosis, a rare case. A rare case with intrahepatic cholestasis. Cholestasis, sir. Yes, sir. I don't know, sir. So cholestasis. Yes, sir. Yes, sir. Yes, sir. Conjugated hyper. Yes, sir. Yes, sir. If there is stone biliary duct obstruction, we'll call it extrahepatic obstruction. In the collecting duct and the common bile duct.
Yes.
Yes, sir. Extrahepatic cholestasis.
Yes.
Yes, sir.
It is there.
Yes, sir.
Right. So your inference was that cardiac amyloidosis is related to intrahepatic cholestasis.
Yes, sir.
How did you corroborate it?
So actually the patient when came, she had symptoms of heart failure with raised bilirubin. But to our surprise, sir, SGOT and SGPT was absolutely normal. If patient has right-sided heart failure with congestive hepatopathy, SGOT and SGPT is generally raised, which was not there. And as a part of routine investigation in our emergency department, we always do ECG of patients. And ECG was very confusing. We were getting QS complexes and poor RV progression in all the leads. And we were suspecting, okay, something is wrong with her heart. We were suspecting regional wall motion abnormality in that patient. We went ahead with the echo, sir, and all the classical ECG. And ECG echo discordance was where we suspected that she could have cardiac amyloidosis.
Tell us about one physiological cause of cholestasis and one drug leading to cholestasis. Physiological cause of cholestasis.
Pregnancy, sir.
And one drug for the cholestasis.
Okay.
Any antitubercular?
Pyrazinamide, rifampicin, isoniazid. Okay. Not very sure. Pyrazinamide. Isoniazid. Okay, isoniazid.
What is Corvizer's law?
Pardon, sir?
Corvizer's law.
Corvizer's law. Sir, in chronic cholecystitis, if we are able to palpate it, then it is double impaction show karta hai, sir. I'm not able to say in chronic. Will pardon? Confused a bit, sir. Okay. Okay. Thank you.
Hello. Thank you so much. Moving ahead, I would like to request Dr. Vinay Kumar Verma to please join us on the dais.
Hi, my name is Vinay Kumar Verma, Medicine PG, Bhagalpur. My guide is Associate Professor Dr. Rajkumar Chaudhary, sir. My topic is diabetic gastroparesis. Introduction. Gastrointestinal sensory motor abnormality are common in patients with diabetes mellitus, and it affects almost 50 to 60% of patients with long-lasting diabetes. Symptoms accompany are impaired motility and emptying of GIT tract. Pathophysiology. Diabetic gastroparesis, pathogenesis and clinical features. Its pathophysiology occurs from many regions like autonomic neuropathy, loss of neuronal nitric oxide synthase leading to loss of nitric oxide, increased oxidative stress with loss of upregulation of protecting enzymes such as heme oxygenase 1, loss of interstitial cells of Kajal with resulting gastric arrhythmia and delayed gastric emptying, a smooth muscle atrophy and loss of IGF-1 from smooth muscle cells, loss of macrophages expressing heme oxygenase 1. Symptoms occur like nausea, vomiting, epigastric pain, EG satiety, belching, regurgitation, postprandial fullness, and weight loss. Case study. A 65-year-old female presented in JNMCH emergency with chief complaints of pain abdomen, nausea, bloating, and dryness of mouth since 2 to 3 days. Patient is known case of type 2 diabetes mellitus since 15 years, and from 5 years she is on basal insulin and bolus insulin. The symptoms recurred every 2 to 3 months, for which she has been admitted many times in emergency. At the time of admission, patient had BP 116 by 74 mm FHG, pulse rate 88 beat per minute, and RVS 40 milligram per DL. Patient is kept on basal insulin and antibiotics, PPI and levosulfide and IV fluids. On investigation, patient has hemoglobin of 9.8 gram per DL, WBC 7000 per DL, HbA1c of 8.6%, potassium 4.5 millimole per liter, and TSH of 6 international unit per DL. After treatment, patient symptoms improved with 3 to 4 days. Patient is discharged on Lentus and regular insulin, PPI, levosulfide, and probiotics. At the time of discharge, patient is counseled for regular blood sugar monitoring, high fiber, low fat diet, and regular follow-up. Diagnosis. We do many tests like 4-hour gastric scintigraphy is the gold standard. 13 carbon based breath test can be used in the office setting. Ultrasound is non-invasive and provides information on emptying as well as segmental function, but depends on operator expertise. Capsule allows measurement of pH, pressure, temperature, and emptying at the same time. MRI can help determine intragastric content and emptying without radiation exposure, but still requires significant experience to interpret. Aspect imaging allows measurement of aspect imaging allows measurement of gastric emptying and accommodation concurrently. Management. Nutrition therapy, hydration and correction of electrolyte imbalance, micronutrients, vitamin, cobalamine, vitamin C, etc. to attain glycemic control, prokinetic agents, anti-emetic agents. First, when patient comes with this symptom, we have to suspect presumptive diagnosis of gastroparesis. We have to do for dietary measures and then consider all. Hello. Hello. Presumptive diagnosis of gastroparesis. Then we have to do dietary measures. Then have to consider upper GI endoscopy or esophageal gastroduodenoscopy, and SVPT to rule out mechanical obstruction. Then empirical trial of prokinetic agents for 4 to 8 weeks and antiemetics as needed. If there is improvement and mild symptoms present, then pulse therapy with prokinetic agents are given. If severe symptoms, then continue therapy with prokinetic agents. If there is no improvement after prokinetics, we have to perform 4-hour gastric emptying study of prokinetics. If it is normal, then consider other causes like medications, rumination, eating disorder. If it is abnormal, then higher dosage of prokinetics alone or in combination. If it is improvement, then consider continue prokinetics. And if there is no improvement, then we have to do for further surgical management like Billroth, burn to or ruin by surgery, and consider drugs like domperidone, jejunostomy, and gastric electrical stimulation with or without jejunostomy. Thank you.
Your was diabetic gastroparesis. Final outcome is due to?
Due to diabetes not maintained. डायबिटीज का मेंटेन नहीं रहता था, इसी कारण ऑटोनोमिक न्यूरोपैथी कारण.
Okay. Now tell us something about autonomic diabetic complications. Autonomic.
Postural hypotension, resting tachycardia, palpitation, and even sweating, hypoglycemic unawareness. Even it may be sexual dysfunction, erectile dysfunction, autonomic.
What is achlorhydria?
Achlorhydria. It may be due to the autonomic region. If there is persistent low HCl secretion from the in the GIT from parietal cells.
Due to deficiency of what?
Due to deficiency of parietal cells, HCl, hydrochloric acid. Or
one surgical cause for hypo or achlorhydria.
Surgical cause for hypochlorhydria or achlorhydria.
Surgical cause.
Total gastrectomy. Thank you, sir.
Thank you so much. I would like to call next speaker, Dr. Akash Sharma, to please join us on the dais.
Good afternoon, everyone. My topic is high sensitivity CRP protein as a prognostic marker in acute myocardial infarction. Introduction. Acute MI continues to be the major health problem in the developing countries like India. Evidence is emerging that medical practice does not adequately implement preventive actions in asymptomatic high-risk individuals and patients with established coronary artery disease. Thus, these patients remain at substantial risk of disease and death. It is becoming increasingly clear that inflammation is an important factor in acute myocardial infarction. High sensitivity CRP is an acute phase reactant protein that reflects early inflammation response, has emerged as a simple tool for risk assessment for coronary events in general population. High sensitivity CRP levels might reflect local inflammation process in the coronary artery or as an intensification of focal inflammatory process that destabilize the vulnerable plaques. We aim to assess the prognostic value of high sensitivity CRP as a prognostic marker in acute MI. Objective. The study was conducted to find a relationship of high sensitivity CRP and acute MI in a patient at a time of admission and their association with in-hospital complications due to MI. Materials and method. 100 AMI patients that were admitted in KMC medicine department were the subject of this study. The study was approved by Institutional Ethical Committee and a written informed consent was obtained from all the patients. An observational study was conducted and a patient was followed up for 20 days in a hospital. High sensitivity CRP was done in all the patients admitted in the emergency. Inclusion and exclusion criteria. The patient with typical ischemic chest pain, raised cardiac enzymes, typical ECG findings were included in this study, and patient with prior history of MI or heart failure, patient with deep vein thrombosis or thrombotic diseases, patient with uremia and severe liver diseases, and patient with infection and malignancy were excluded from this study. Results. Of the 100 patients, 89 were males and 100 were females. Maximum patients were aged between 41 to 50, followed by 61 to 70 years. Among 100 patients, 79 patients has an increased high sensitivity CRP that is more than 3 mg per DL, and other 21 patients has a normal high sensitivity CRP. On follow-up, the patient with increased high sensitivity CRP show cardiovascular complications like recurrent angina in 32% of the patient, heart failure occur in 24%, arrhythmias in 11%, and death occur in 10% of the patient. Patient with normal high sensitivity CRP did not develop any complication during this period. Conclusion. The study conducted demonstrated that there is a significant association between high sensitivity CRP and is associated with serious complication after the AMI. And thus we can conclude that high sensitivity CRP can be used as a potential prognostic marker for the complication and death post-acute myocardial infarction. Thank you.
You have taken up CRP as the prognostic marker.
Yes, sir.
Could you tell me a few other prognostic markers which may prove better than CRP in acute myocardial infarction? Now let us keep it simple.
Yes, sir.
How do you diagnose myocardial infarction, acute myocardial infarction?
So the patient with typical chest pain.
You talk on that.
The patient with typical chest pain with coming to the emergency.
One is clinical.
Yes, sir.
Sign and symptoms.
Symptoms.
Now comes the biochemical and then electrocardiographic.
Sir, in electrocardiographic, there can be two changes. ST elevation can be seen, and a patient with elevated cardiac enzymes, like TROPI and CKMB, sir.
So now you have got few enzymes with you.
Yes, sir.
TROPI is there,
Yes,
then CKMB, some LDH, and everything. Now, what may be the prognostic markers? Better. इसी में से कुछ बोलो.
Sir, we can use CKMB. TROPI can be used, sir. Troponin can be used, sir.
What is the earliest electrocardiographic change in acute myocardial infarction?
Sir, ST elevation.
First, which is related to release of intracardiac potassium over the site of infarction.
Sir, T elevation, sir.
Hyperpotassiemia क्या करेगा? What is the AC change in hyperpotassiemia? Hyperkalemia.
Hyperkalemia, sir. Sir, tall 10 T waves will be seen, sir.
Thank you so much. Moving ahead, I would like to request our next speaker, Dr. Animesh Paul, to please join us on the dais. And meanwhile, I would like to announce those who have completed their talk in this hall can proceed to the hall A.
Good afternoon. We did a study of demographic, clinical and biochemical profile of patients with fibrocalculous pancreatic diabetes or FCPD, or popularly known as type 3C diabetes in the northern part of Bihar. It was conducted in MGM Medical College in Kishanganj, Bihar. FCPD is a unique secondary form of diabetes found mainly in tropical region characterized by abdominal pain, pancreatic calcification without development of ketoacidosis. It involves patients with poor socioeconomic status, malnourished and lean body build. It is a very brittle type of diabetes, often insulin dependent and very difficult to manage. Radiological analysis shows presence of pancreatic calculi with atrophic pancreas. In India, largest number of cases are reported from Kerala. The prevalence of FCPD in general population is 0.019%. Etiopathogenesis is not clear yet, although various postulated hypotheses are there, like malnutrition, cassava diet, oxidative stress and autoimmunity. There has been a significant changes in demographic, clinical and biochemical profile of the patients having FCPD noted in the last few decades. Thus, it's not दिखा नहीं रहा है. Thus our study aims to evaluate the clinical, biochemical and demographic profile of the patients with FCPD and to evaluate the change in the trends of the FCPD over the last 3 decades. In the methodology, it is a hospital-based prospective observational study duration for 12 months, and the study participants are OPD and IPD patients with diabetes. The diagnosis of FCPD was made by criteria proposed by Mohan et al. That was supposed to be the criteria. With which we diagnosed the FCPD cases. In the methodology, we have collected the demographic details, clinical examination and clinical history along with various anthropometric measurements and various laboratory tests and radiological investigations, and all the data were analyzed using Microsoft Excel. Coming to the results, total 10 patients we have found in a span of 1 year, out of which 9 were male and 1 female, with a mean age of 28.44 years, and the 50% of the patients were less than 30 years of age. The mean duration of diabetes was 4.4 years, and 70% of the cases has less than 5-year duration of diabetes. 2 patients had family history of diabetes, but not 3 consecutive generations. 1 had history of occasional alcohol intake. No patient consumed Kejava. 6 patients presented to us with osmotic symptoms. 4 patients presented to us with various infectious disease-related symptoms along with uncontrolled diabetes. Mean BMI of our population was 19.42, with 20% patients having low BMI, which is less than 18. Mean waist hip ratio is 0.89. Mean tricep skin fold thickness 9 mm and subscapular skin fold thickness 10.6 mm. All the patients having poor glycemic control with mean fasting blood sugar 231, ppbs 469 and mean HbA1c of 11.96. Mean total cholesterol 180 and triglyceride 142. Mean creatinine was 0.87 and albumin creatinine ratio was 27.23. All the patients required insulin with a mean insulin dose of 0.8 international unit per kg. 1 patient had neuropathy. 1 patient had both neuropathy and retinopathy, nephropathy and retinopathy, and 1 patient had only nephropathy. No patient had macrovascular complications. No patient developed diabetic ketoacidosis. This is the chart. Coming to the discussion, a study done by Yasnik and Shelgaikar in 1993 in Maharashtra, they had a mean age of 22 years for FCPD with a BMI of 17, and 58% patients had low BMI. As compared to our study, where there is considerable change in the trend, like we have mean age a little bit high and mean BMI also high, and only 20% patient low BMI. There is a considerable change in last 3 decades, probably due to the improvement of socioeconomic status and nutritional status. Mean HbA1c in their study was 10.6, and in our study is 11.96. In Levitt and Associates found 33% of the pancreatic diabetic patient had retinopathy and 23% had nephropathy. In another study done by Mohan et al., the complications were retinopathy 30%, peripheral vascular disease 4.7%, neuropathy 20%, nephropathy 10%. In our study, there is significantly less number of diabetes-related complications, micro or mesovascular complication, probably due to the less number of participants and less mean duration of diabetes, which is only 4.4 years. Conclusion, FCPD is a form of secondary diabetes, remains confined to tropical countries like India. It is a very brittle type of diabetes in nature, often requires early insulin therapy to control. Over the time, there has been a significant change in the trend of the disease with respect to demography, clinical profile and prognosis due to proper diagnosis, early treatment and improved nutritional status. Thank you.
So what was the relation of cassava with pancreatitis?
Sir, it was postulated in South India, cassava is very much consumed. So in malnourished people, there is methionine deficiency. So cassava leads to cyanide toxicity in that cases, which was main reason to develop tropical calcific pancreatitis. But in subsequent studies, it was not a very sound, this theory is not very sound, because it has been shown that in the areas where cassava has not been consumed, there also tropical calcific pancreatitis are developing. And in some areas where people are regularly taking cassava, there was no tropical calcific pancreatitis. So cassava hypothesis is now a little bit questionable.
What is NCPF?
Sir?
NCPF.
NCPF.
Non-cirrhotic portal fibrosis.
It is due to portal hypertension due to not in cirrhosis patient, not in liver cirrhosis patient.
This is again by the ingestion of herbs found in the suburbs of Punjab.
Yes, sir.
Cassava is the same herb found in South India.
Yes, sir.
And it is a proven entity in the books, NCPF.
Yes, sir.
And that leads to cirrhosis in other words.
NCPF, yes, sir.
So what do you think? What did you ascribe with this? Your study, what?
To see the trend, first to see the prevalence, like if the cases are present in northern part of Bihar, and we have found quite a lot of cases in our hospital of FCPD, and we are now mainly to determine the change in the trends, because it has been shown that over the last 3 decades there have been a lot of changes in the trend. Earlier it was thought to be a disease of only malnourished people with low BMI, but now people with BMI of 20-21 also getting the disease. Earlier it was diagnosed at very early age, like in people in 20s. Now it has been diagnosed in the late also, like people after 30 years also. We have got case with 40 years people also diagnosed with FCPD.
Okay.
And
Thank you.
thank you, sir.
Hello. Next up, I would like to call Dr. Ankit Chandra to please join us on the stage. I would like to mention the next 3 speakers, Dr. B. Anil, Dr. Deepak Kumar Thakur, and Dr. Pushkar Kumar.
Hello. Very good afternoon to respected faculty members and all my colleagues present here. Today I'll be talking about extrapulmonary rifampicin-resistant tuberculosis in a diabetic patient. Introduction. The tuberculosis is a communicable disease caused by Mycobacterium tuberculosis, primarily affecting the lungs, causing pulmonary tuberculosis. But it is also involved in causing extrapulmonary tuberculosis, in which sites of the body other than lungs are affected. Rifampicin-resistant tuberculosis is defined as TB caused by strain of Mycobacterium tuberculosis which is resistant to rifampicin. Coming to pathogenesis of drug-resistant tuberculosis, this diagram depicts the various mechanisms by which the bacteria develops rifampicin resistance. First one, the factors driving poor drug availability or poor adherence leads to selection of resistant bacteria among the population, and then these populations are multiply and predominate the bacterial presence in the lungs. Second mechanism is the presence of efflux pumps among the bacteria, which lowers the concentration of drug among the inside the bacteria and help them in multiplying. Third mechanism is due to pharmacokinetic variability among the person to person variations. The fast metabolizers have lower drug concentrations in their body. The fourth mechanism being the sites of body where tuberculous bacilli is present, where the places where low drug concentration is achieved are prone to generate drug resistant form of the bacilli. Coming to the case study, a 37-year-old male hailing from Sahebganj came to JLNMCH Bhagalpur with complaints of shortness of breath at rest and chest pain, left side since past 1 year. 8 months ago, he underwent pleural tapping and anti-tubercular therapy. The first line was statin. Diabetes mellitus was diagnosed 1 year back, for which he took treatment irregularly. On examination, there were decreased chest movements on the left side. Percussion revealed stony dullness on the left side, and breath sounds were not heard on the left side. The findings were suggestive of left-sided pleural effusions. Important investigation findings were the presence of random blood sugar being 508 and HbA1c of 8.2, and pleural fluid was sent for CBNAT, gene expert, which detected Mycobacterium tuberculosis, and rifampicin resistance was detected. Chest X-ray and PA view and ultrasound chest showed left-sided pleural effusion. Next slide, please. It's not working. So yes, the first X-ray on the left side shows the first X-ray which when the patient presented to us, and the second X-ray on the right side shows 15 days later. In the meanwhile, we did intercostal drainage was done, and pleural fluid was sent for examination, which showed rifampicin resistance. The middle report. Upon the diagnosis of rifampicin-resistant tuberculosis, patient was started on all-oral longer bedaquiline regimen, and which comprises of linezolid, levofloxacin, clofazimine, cycloserine, bedaquiline, and pyridoxine, 18 to 20 months of regimen. And insulin was also started on this patient to control the diabetes. And patient was monitored for adverse drug reaction and then discharged with referral to local government hospital for further treatment. Thank you.
How did you diagnose rifampicin-resistant tuberculosis?
Sir, gene expert test, cartridge-based nuclear amplification test, sir.
No, you did it with pleural effusion.
Yes, sir. Pleural fluid Sibinat.
Now you tell me, what are the fluids or the thing in the body with which we cannot do CB0?
Blood, urine, stool sample.
Right. What is XDR tuberculosis?
XDR tuberculosis is resistance of Mycobacterium tuberculosis to rifampicin, isoniazid, fluoroquinolones, and linezolid or bedaquiline or both. Thank you, sir.
What is the percentage of CB0 positive in pleural effusion?
For
if anybody has pleural effusion,
30 to 40%, sir.
32%. And how many cases you have seen in our college?
Out of till 1st December this year, 419 cases of MDR tuberculosis were admitted in our college. 4 of them were of pleural fluid MDR TB.
Is there any relation with diabetes?
Diabetes predisposes to tuberculosis. In this case, diabetes could lead to a failure of treatment of initial drug-sensitive tuberculosis, which went on to develop drug-resistant tuberculosis.
Previously, he was given first-line drugs?
Yes, sir, for 6 months.
For 6 months?
Yes, sir.
He completed the course?
Yes, sir.
Okay. And last question, is the question bhul gaya hum puchna.
Initially, he received treatment for 6 months.
Yes,
for
sir.
What?
Pleural effusion, sir.
This person had pleural effusion 6 months back.
Yes, sir,
and
nice.
without having CB0,
Yes.
patient was put on first-line drug.
Yes.
And then again, he was not recovered and then came to the hospital.
Yes, sir.
And then you had your this pleural effusion test for CB0.
Yes, sir.
And then you diagnosed that it is a rifampicin-resistant tuberculosis.
Yes, sir.
So you think that the first 6 months treatment is wasted?
There are 2 possibilities, sir. The first one is that the patient had drug-sensitive tuberculosis, and due to diabetes, there was treatment failure, and patient went on to be
Diabetes doesn't make resistant tuberculosis. You must
increased survival of.
infected by a resistant tuberculosis positive case, then you can become.
Yes.
Or there is insufficient introduction of drugs for insufficient period. 3 times. Infection with drug-resistant TB. Number 1, inadequate time and inadequate dose. क्या यही है ना?
Yes, sir.
These are the 3 conditions. पहले ही लगता है वो था.
Yes, sir. The second possibility is that he was drug resistant initially. Yes, sir.
Why he was put on longer bedaquiline treatment, oral treatment? Why not shorter regimen?
Because as per the guidelines, extrapulmonary tuberculosis cases are started on all oral longer bedaquiline regimen, sir.
Can you say the exclusion criteria for longer? Exclusion criteria.
If the patient has drugs which are sensitive to shorter oral bedaquiline regimen, then we can use it.
Other?
Children less than 5 years of age.
Okay, thank
you,
you,
sir.
Thank you so much. I would like to I would like to request our next speaker, Dr. B. Anil, to please join us on the dais.
A very good afternoon, DICE personals. Myself, Dr. B. Anil, AIMS Patna, General Medicine resident, will be presenting a case of pain abdomen, a challenging case of pain abdomen. Our patient, 34 years male, presented with pain abdomen since 8 days, black stools for 6 days. The patient was apparently all right 6 days back. To start with, he developed abdominal pain, suddenly onset, diffusely felt over whole abdomen, colicky in nature, radiating to back, progressively worsening. It relieved on taking medication, pain increased with food, relieved on empty stomach, no history of heartburn, fever, cough, chest pain, nausea, vomiting. No history of burning micturition also. Also, he is complaining of dark stools, which was not sticking, passing 2 to 3 times per day, associated with no pus discharge. The past history is suggestive of no similar history, but he has generalized weakness for which he already took 2 units of PRBC 5 years back, and also took 2 units of PRBC 2 years back. From outside, he was taking supplementation of vitamin B12 injection since 4 months. So, and jaundice also, there is a history of jaundice also 8 years back. No history of severe illness in family and no premature mortality. Personal history, construction worker by occupation, and nothing significant here. General examination. Conscious identity to time place person. BP is normal, 120 by 90s. Heart rate 105 per minute, regular. Moderately built. Pallor was present on examination. Neck vein not engorged. On per abdomen examination, no grossly engorged veins over abdomen. Soft, tender, and deep palpation on right upper quadrant and bilateral flanks. Liver not enlarged, not palpable. There is no shifting dullness. RX examination, CV examination was relatively normal only. CNS, it was grossly normal only. Differentials, we thought peptic ulcer disease because of pain abdomen and history of melena, and second is acute pancreatitis and acute cholecystitis. The initial investigation suggestive of hemoglobin 6.4, WBC 5.6 K, and with an NL ratio of 65 and 30. Platelets were 150 K. Peripheral blood smear suggestive of normocytic normochromic anemia admixed with few macrocytes. Anemia workup done. It was suggestive of anemia of chronic disease. Contrary to our belief that it may be PUD because ferritin is 1000. It cannot be due to blood loss only. Further investigation suggestive of AVG suggesting of metabolic acidosis with pH 7.3 and bicarb 12. Urea and creatinine are grossly deranged. Urea is 225 and creatinine is 15. So we did urine routine examinations suggestive of specific gravity 1.005 with protein creatinine ratio of 303 milligram per gram and no dysmorphic RBCs. Amyloid is in normal limit. Serum amylase was normal and lipase was normal. In view of optimum urine output with lower sided specific gravity, further management done in view of acute tubular interstitial nephritis. Hemodialysis done. Patient generally recovered from the deranged KFT. In view of history of black stools with anemia, esophageal gastroduodenoscopy is done. Noted skull of bile stain mucosal faults. We did further investigation in line of malabsorption syndromes. Duodenal biopsy suggestive of lymphoplasmacytic infiltration and no Willard's atrophy. As the patient is already taking on vitamin B12 supplementations, we thought it is to be case of malabsorption syndrome only. Then fecal urine also sent. It was in lower normal range, so we thought it is due to mild to moderate exocrine pancreatic insufficiency. During hospital stay, the abdominal pain was subsided on conservative management, and patient was taken to orally from day 2. The abdominal pain occurs on 7-day hospital, on day 7 of hospital illness. Serum lipase came to be 734. Now we thought he has developed acute pancreatitis in the hospital. We ruled out every possible cause of cholecystitis, hypertriglyceridemia, and hypercalcemia. The onset of abdominal pain, feed intolerance, and vomiting starting from day 7 hospital stay persisted till day 14. So we did the CT further. The CT suggestive of thrombus, multiple thrombosis, and liver suggestive of multiple collaterals. So we plan to start anticoagulant, but in the hospital also patient developed another significant fall of hemoglobin. So we thought we are missing something. So we did further workup in lines of hemolytic anemia only. LDH was raised, haptoglobin reduced, and direct cum test was negative, and all autoimmune causes are ruled out. So we diagnosed the cases of, we did workup for PNH and it came out to be positive. PN is a rare disease which we should suspect an acquired disorder in which hematopoietic cells, stem cells and their cellular progeny have reduced or absent GPI anchored proteins. Factors that contribute to hypercoagulability is like decreased NO and GPI anchored proteins and complemented mediated increased levels of complementary causes hypercoagulability. Renal insufficiency, PNS can be associated with renal insufficiency due to chronic hemolysis only. Conservative management done, and we don't have facility for hematology, hence we referred it to further centers. And the PNS presentation, classical presentation is fatigue, dyspnea, and hemoglobinuria. So our learning point is that we should screen for PNH when we suspect thrombosis involving unusual sites, usually having evidence of intravascular hemolysis, like intra-abdominal sites, cerebral veins, dermal veins, and Budd-Chiari syndrome.
Why did you do duodenal biopsy?
Sir, patient is having already vitamin B12 deficiency and he is having melena. Since he's complaining melena since 6 days. So we were not sure is it melena or some dark stools only. So we did endoscopy, and in the endoscopy they suggested that this margins are scalloped. So
your upper GI endoscopy is enough to find out the upper GI bleed?
No, sir. But stool occult also was negative for 3 times only.
What is specific of duodenal biopsy?
Sir,
which parasite stays over there? What is Encyclostoma duodenale?
Yes, sir. Encyclostoma duodenale.
What is that?
Nematodes. Nematodes, sir.
Normal naam kya hai? Ankylostoma
duodenale.
hookworm.
Vitamin B12 deficiency karta
What
hai.
is the specific of it?
B12 deficiency karta hai.
How many jaws it has got? It has got 4 jaws, and one hookworm sucks about 0.03 ml of blood every day,
Yes.
and it remains there in the duodenum. What else? Biopsy, duodenal biopsy.
Sir, malabsorption, we look for duodenal biopsy only, villous atrophy and all.
Why did you take this paroxysmal hemoglobinuria?
Sir, on CT, after pancreatitis, we did CT because to know how much extent.
How did you suspect?
The multiple thromboses are there.
Like?
Like splenic vein, sir, and liver and renal vein also. Three sites we have we have found thrombus.
What was the color of this urine?
The dark color. Upon probing, in a hospital we did not find anything, but upon probing, he informed that sometimes he has fast dark urines in morning.
What did you see? Did you see
We did not
dark
see,
color urine?
We did not see in the hospital.
You went on the history with the patient?
Yes,
gave
sir.
you.
Yes, sir. We asked some questions and we did that.
Thank you so much. With this, I would like to call next speaker, Dr. Deepak Kumar Thakur.
Good afternoon to all of you. My topic is rare cystic lung disease, that is a pulmonary lymphangioliomyomatosis with a very rare extrapulmonary manifestations. So this is one data. It's showing that LAM is of mainly 2 types. One is genetic LAM and one is sporadic LAM. TSC associated LAM and sporadic LAM. Among these, the most common is sporadic LAM, and among the extrapulmonary manifestation, it is the most common renal angiomyolipoma, hepatic angiomyolipoma, lymphangioliomyomas, and the rare is ascites. So my case is a patient, 25 years old female from Katiyar, unmarried, and a very low socioeconomic status. Her chief complaint is a cough, which is mostly dry in nature for approximately 2 years, shortness of breath for 1 year, and abdominal distension for 2 months. Basic HOPI is a patient is apparently asymptomatic 2 years back. She had a history of cough for 2 years, which is persistent in nature, mostly dry in nature, sometimes associated with watery expectoration and bloody sputum, around 6 to 7 episodes till date. She experienced shortness of breath initially on exertion, gradually non-side, and slowly progressive to shortness on walking upstairs. And SOV got relief on taking rest. And she noticed abdominal distension for 2 months, which is gradually progressive and slight pain associated with shortness of breath. Then for pain abdomen and for distension, she consulted general surgeon in Patna Medical College for abdominal distension and did ultrasound which saw a gross ascites and referred the patient for pulmonary medicine department for SOB evaluation. Negativity showed that the patient had no history of trauma to abdomen, no history of weight loss, loss of appetite, light sweat, chest pain, no history of any exposure to birds, pet, and organic exposure. And we also rule out autoimmune symptoms like fever, joint pain, fatigue, rash, muscle, and etc. Past medical history saw that she had a history of fever with seizures and got discharged with tubercle meningitis 4 years back and taking ATT for 1 year, but there's no any documentation present. Family history is not suggestive. Examination is overall normal. A grade 2 clubbing is present. Sorry, on general examination, a grade 2 clubbing is there, with rest is normal. And this grade 2 clubbing seen. Respiratory examination saw only bilateral mid and end expiratory cramp, more on the left side with prolonged expirations. Abdomen showing on inspection, abdominal distension with flank fullness present, which is grossly restricted movement all over the abdomen, and there's a umbilicus is everted also. Fluid thrill is present, septal dullness is present. CNS is normal. On investigation, till date, we must think about, we only think that this may be the case of basic bronchiectasis, but later on doing a ultrasound abdomen, it's showing gross peritoneal collections. PFT showing obstructive nature, and impulse oscillometry showing peripheral airway obstruction, sorry. This is a chylous fluid which is on abdominal paracentesis, and thus fluid is sent for analysis. It's showing the positive finding is ADA is 32.5 with a very high triglyceride level to 1215. That is mostly lymphocyte. Totally this goes in the favor of chylous effusion. Routine blood is normal, HIV is negative, ANA profile is negative, CCT abdomen showing moderate dense fluid collection noted in abdomen, few mesenteric lymphadenopathy noted, largest of size 10 into 6 millimeter with mild surrounding mesenteric fat standing. So this is HRCT, a very typical showing some fibrocystic lesion, but mostly it's showing a uniform round cyst, which is apicobasal in predominance, with slight geosis present. Reporting showing a multiple thin wall cyst noted in a bilateral lung field, or mostly equal in size and some bizarre looking. Slight geos present, few central-lumbral nodularity, and no significant mediastinal lymphadenopathy. So provisionally, in the view of history of chylous peritoneal collection with cystic pattern of lung disease, likely suggestive of lymphangiomatosis with a small airway disease. But now the cytological examination of ascitic fluid showing on hematoxylin and eosin staining, so a cluster of cells present in an inflammatory background of lymphocytes, granulocytes, macrophages, and some mesothelial cells. Cell block also done. It's showing cells, similar cluster of cells seeing, which is similar in size, central, with the peripheral having a marginal cell of flattened. So for better clarification, pathologists to do immunohistochemistry, but due to financially not done. Bronchoscopy BAL done, it was normal. Transbronchial lung biopsy not done, sir. This is a LCC, that is a lamb cluster cell. It's showing a central, very circular cells and peripherally having flattened cells. So my final diagnosis was, based on history and investigation, my final diagnosis is a pulmonary lamb with a chylous effusion. The other most common differential is pulmonary Langerhans histiocytosis. Patient was discharged with a regular follow-up with spirometry and see the progression. This is an ATS guideline to see how to diagnose a pulmonary lamb. Definitive lamb is showing having a definitive lamb having a characteristic CT scan with having any one of the following features, like presence of tuberous sclerosis complex, angiomyolipoma, serum VEGF-D more than 800 picogram per ml, chylous effusion, lymphangiomyomas, lamb cells demonstrated on the chylous fluid, and histopath of lamb cell by lung biopsy. So this is the last slide showing the treatment part. Learning point is, lamb is a neoplastic multisystem disorder, and clinical features other than cystial disease on imaging may be prominent on presentation. After chest CT, serum VEGF-D is initial investigation, but this is not done in all over the India. In the absence of malignancy, the diagnosis of lamb should be considered in cases of non-traumatic allothorax and chylomperitoneum. Thank you, sir.
So what suspicion did you get? How
Sir.
did you suspect?
So actually the histology showing a cluster of cells. So basically it is a lamb cluster cells, which is showing central area of circular cells and peripheral marginal cells of flattened, which is showing a lymphatic endothelial cells. So my final diagnosis is lamb, sir. So we have to do immunocytochemistry to prove whether it is definite lamb or it is just a probable lamb, sir. This is the one very bridging point, sir.
The lesion which was present in the lung.
Yes, sir.
The differential diagnosis of that particular lesion may be 1, 2, 3, 4. Lamb stands the last.
Yes, sir. But in the female patient of reproductive age group, sir,
What may be the differential diagnosis?
there may be pulmonary Langerhans histiocytosis, which may be the second differentials, and some genetic cause like BSD disease, like LIP, sir, like DIP also.
How
Because
many lesions were there in the lung?
very large lesions, sir, around.
Only one?
No, sir.
Multiple?
Multiple lesions, multiple.
Now tell me the differential diagnosis of multiple lung lesion, bilateral. Differential diagnosis.
Not a cystic, sir. It's just a common.
Common.
It may be viral pneumonia, sir. It may be systemic, like vasculitis, sir. It may be cryptogenic organized pneumonias, and then maybe cystic like LAM, PLCH, sir. And maybe sarcoidosis, sir.
LAM is at the last. It is not a common diagnosis.
Yes, sir. Definitely, sir.
Thank
It's a LAM in sporadic is having good prognosis, sir. We started the sirolimus 2 milligram per day, and to see the progression, whether the symptom resolution, the chylous fluid is decreased or not, and to see any CT scan changes or not, sir. But tuberous sclerosis LAM is very just a very bad prognosis, sir. Sporadic LAM is a good prognosis, sir. Not good, but it is gooder than TSC LAM, sir. It's a good, sir. Around 60%, sir. In 2 years, sir. Sir, in this case of LAM, we did not say about the survival rate. We think about the transplant-free survival, sir. That is of 2 years, sir. In every disease, we see about the survival rate, but in this case, we see about the transplant-free survival, sir. It is of 2 years, sir.
How do you assess the
Yes, sir?
progress of the disease?
To see VEGF data, sir. Vascular endothelial growth factor, if it is decreasing, generally it is more than 800. If it is decreasing, we see it's a good follow, sir. And the CT scan showing a decreased cystic lung disease, and the chylous effusion also decreased. These are the three parameters in which we see the treatment is responsive, sir.
Hello.
Thank you.
Hello.
Thank you, sir.
Thank you so much. I would like to call our next speaker, Dr. Pushkar Kumar, to please join us on the dais. And the name of next three speakers, Dr. Archana Kumari, Dr. Rija K. Anthony, and Dr. Shauvik Chatterjee.
Good afternoon. I am going to present a case of rare case of progressive supranuclear palsy. It is a case of a rare movement disorder from DMCH. We start with the history first. A 50-year-old male farmer presented with complaints of tremulousness for the last 2 years, along with progressive slowness of movement for the last 1 year, and he also gave history of recurrent fall for the past 1 year, with bouts of sudden uncontrollable cry for the last 3 months. There were no complaints of forgetfulness, bowel bladder disturbances, and no history of trauma was there. History of presenting illness, patient was apparently all right 2 years ago, until he developed gradual slowing of routine day-to-day activities. Over the past 1 year, he had recurrent falls. He also frequently tripped over any raised obstacles in his path over the past 3 months. History of stiffness was there in all 4 limbs. There was no history of weakness of the limbs. However, he needs a walking stick for the support for the last 6 months. There was no history of involuntary movement, no history suggestive of sensory impairment, and also the bowel bladder the bowel bladders were normal. Past history, there is no significant past history, like he is not having hypertension, asthma, or any epileptic history. The one important point was that he was previously been given with levodopa and Pacitin for his tremors, and he was being treated by a private hospital on the Parkinson's disease for the last 2 years. But the patient was not responding. Personal history, he was not a smoker but used to consume alcohol. There was no significant family history. Now, when we examined the patient, patient was conscious, cooperative, and oriented to time, place, and person, but was poorly built and nourished with generalized wasting. The blood pressure was normal, but that is 122/80. Pulse was 92 per minute. Temperature is normal. There were bilateral tremor in both upper limbs. There were staring look on the face, curved up position with inability to lie flat in the bed. There was also extended neck and head, widened palpebral fissure, and reduced eye blinking. You can see the staring look on the face. There were no signs of autonomic dysfunction. Rest of the examination was normal. Systemic on CNS examination, conscious, oriented, handedness of the right. He was having dysarthria, slight. Sleep was of poor quality. Memory could not be tested. Cranial nerves were tested, and it was found that there were vertical upgauge palsy was there with mild eyelid apraxia, normal pupil size, and reactivity. Motor system, in the right upper limb, the nutrition was poor. In the left, poor. The tone is increased in both right and left upper limb. Also in the lower limb also. The tone was increased. The power was 4 in both right and left upper limb. Coordination was normal. There were extrapyramidal system finding like bradykinesia. Involuntary movements, there were tremors present. Reflexes was normal. We went for CBC. It came to be normal. Then we moved on to CT scan. It was also normal. So suspecting some movement disorder, we went for MRI. In MRI, we characteristically get a hummingbird sign, which is a sign of midbrain atrophy. We confirmed in another sections, which was the sign of another midbrain atrophy, there is a Mickey Mouse sign. And finally, the report confirms it. They gave us neurodegenerative etiology, oblique supranuclear palsy. So what were the differentials? Since the patient was being treated on for the tremor disorder, so the first thing first, Parkinson's and also atypical Parkinsonism. So how do we reach the diagnosis? First of all, we initially thought of Parkinson's, but there were some 1 or 2 more symptoms, like infrequent presentation was there, like vertical gaze palsy, slowing of saccades and pursuits, which tilted our diagnosis towards atypical Parkinsonism. That is, something was extra. So these, so we suspected PSP then only. So how do we differentiate early falling and gait disturbances in PSP? Symmetrical onset of symptoms, rare resting tremor, there were marked decreasing blink rate, vertical gaze palsy was one of the most important clincher in this case, and astonished facial expression which we could appreciate on the photo. Changes in mood and behavior and little response to Parkinson's medication was the clue to go with the PSP. So the treatment was drug therapy. It has levodopa has a little role. However, it can treat some Parkinsonian features. Physostigmine and zolpidem has been tried nowadays. So prism glasses were given for saccades and vertical gaze palsy improvement. Thank you. Sir, since the patient presented to us with symptoms of extrapyramidal symptoms like tremors and spasticity, so we first thought of he must be having Parkinson's disorder. He must be having Parkinson's disorder, and given the patient was also being treated from the outside with levodopa and other anticholinergic drugs. But what we noted in that patient extra was 2 or 3 findings. Like first, the vertical gaze palsy. Second was the staring look of the patient. Third was the frequent history of like tripping onto the raised obstacles, like going down the stairs, he used to fall, and he cannot, like in Parkinson, we see that patient is having stoop posture, but he is having like bended posture, the neck was dystonic. So this
treatment-wise in
yes,
Parkinson's and this representation with the conventional treatment of Parkinson's, what is the difference in PSP?
Sorry, sometimes what happens is that PSP comes along with Parkinson's in certain very small group of patient. In that cases, if tremors is present, signs of other Parkinsonian symptoms are there, we go with the levodopa and pacitin. If it is not present, then we can only, what we can do, we are having very less therapies nowadays. The advances are, they are having tau-based directed therapies. So,
will there be any benefit from DBS?
So those therapies are still in the trial mode, sir. The data are very limited, so we can't say whether they are improving the quality of life or not.
Is it helpful in Parkinson's, classical Parkinson's?
No, sir. They have not been tried in Parkinson's still. Tau-based therapies.
It is proving worth in Parkinson's. Thank you.
Thank you, sir.
Thank you so much. I would like to call the next speaker, Dr. Archana Kumari.
Good afternoon, everyone. Myself, Dr. Archana from PMCH, going to present a case of familial hypercholesterolemia with multiple xanthoma. Excuse me. My patient, 18-year-old female, Muslim by religion from Darbhanga, unmarried, came to my OPD. Came to OPD with chief complaint of multiple disfiguring swelling all over body since last 5 years, which was gradually increasing in size. There is no history of pain, discharge, discoloration or raised temperature associated with swelling. On examination, multiple round yellowish to screen colored swelling noted over the extensor aspect of both elbows, hands, knees and foot in variable size. Swelling is non-tender and fixed to the underlying structure, but skin over the swelling is mobile and normal in temperature. Fluctuation test is negative, no any restriction in the range of movement. Here are some photographs of patient showing swelling, round to oval in size, 3 to 4 centimeter. Past medical history, no significant past medical history. There is no history of chest pain, joint pain or stroke in past. Personal history, no significant personal history. No history of smoking or any other addiction. No any medication taken up by patient for the swelling or surgical excision done for the same. Menstrual history is normal. Family history, there is significant family history. History of similar complaint in her mother and 27 years old brother. History of death of her maternal grandfather due to myocardial infarction at the age of 50 years. Here are photograph of her brother showing xanthelasma in both eyes and tendon xanthoma. There is also swelling over bilateral knee joint. On general examination, xanthelasma in both eyes in upper and lower eyelids, no pallor, icterus, cyanosis, clubbing, lymphadenopathy or edema. Vitals are within normal limits. Other system review were normal. Laboratory investigation. Lipid profile reveals total cholesterol level 450 mg per dl and LDL cholesterol level 385 mg per dl with normal level of triglycerides and HDL cholesterol. Lipid profile of her brother and mother also almost similar values. Histopathology. For FNAC of swelling showed scattered spindle cells with bland nuclei in a background of foamy macrophages and benign adipocytes. 2D echo shows normal aortic valve with no evidence of CAD. Color Doppler of bilateral carotid artery shows no intimal thickness. Diagnostic criteria of hyperlipoproteinemia is cholesterolemia is Dutch Lipid Clinic Network criteria and other is modified Simon-Broom criteria. Based on the Dutch Lipid Clinic Network criteria, she has got total score of 17, which comes under the diagnosis of definite familial hypercholesterolemia. As the genetic testing refused by patient, based on clinical criteria, this is a case of heterozygous familial hypercholesterolemia. Their differential diagnosis: cetoasterolemia, cerebrotendinous xanthomatosis, polygenic hypercholesterolemia, hyperbeta lipoproteinemia. Then now comes to screening. Whom we should to screen any patient with age 20 or less than 20 years with LDL cholesterol level 160 or more than 160, age more than 20 years with LDL cholesterol level more than 190 mg per dl, history of familial hypercholesterolemia in family or LDL cholesterol level more than 240 in either parent, tendon xanthomata at any age, corneal arcus senalis in less than 45 years of age or tuberous xanthomata in 20 to 25 years of age group. Cascade screening. Cascade screening include lipid profile test in all first degree family members of patient diagnosed with familial hypercholesterolemia. The odds for detecting familial hypercholesterolemia in first, second and third degree relatives is 50%, 25% and 12.5% respectively. Here is the photograph of diagnosis and treatment of heterozygous familial hypercholesterolemia. What is the target in treatment? LDL cholesterol should be less than 100 mg per dl without CVD. It should be less than 70 with CVD. In children, it should be less than 135 mg per dl. What are the treatment modality of hypercholesterolemia? Dietary and lifestyle modification. It is the starting point of LDL cholesterol loading in patient with FH. but multi-drug treatment is needed. In addition, all patients of FH should be counseled on the importance of not smoking, vaping, regular exercise, and maintaining a healthy body weight. Drug therapies for adult FH. Statins. Various organizations Excuse me. Slide is not going back. So management, lifestyle modification, and another is drug therapy. In drug therapy, first of all, statin. Statin is the drug of choice for familial hypercholesterolemia. In patient, if after statin there is no target achieved by statin, then we should move to ezetimibe or PCSK9 inhibitors. And also, if not responding to statin, then we add ezetimibe or PCSK9 inhibitors, and additionally there is also various type of like lipoprotein apheresis. Sorry, sir. Bempedoic acid. Bempedoic acid. I write it here, sir. Yes, sir. I write it in the slide, but I just blank out. Yes, sir. But ये on नहीं हो रहा है. Yes, sir, I write it in the slide, sir, actually. अच्छा. Yes, sir. So drug therapies, statins. Sir, can I start again? Statins, various organizations recommended treating patients with FH with high doses of high intensity statins, which are capable of lowering LDL cholesterol itself by 50 to 60%. If high doses, high intensity not tolerated, then we can prescribe moderate intensity or even low intensity. That can also reduce LDL cholesterol by 30% to 50%, and low intensity reduces cholesterol by 30%. Here is the photograph of high intensity, moderate intensity, low intensity. High intensity is torvastatin 40 to 80 mg or rosuvastatin 20 to 40. In moderate intensity, reduction is by 30 to 50%. Atorvastatin 10 to 20, fluvastatin, lovastatin, pravastatin, simvastatin, pitastatin, rosuvastatin. And in low intensity, fluvastatin 20 to 40, lovastatin 20, pitavastatin, pravastatin, simvastatin. Ezetimibe. Next, after statin, we should prescribe ezetimibe, which targets NPC1L1, Niemann-Pick C1-like protein 1, and inhibits the absorption of cholesterol from intestine. The improved trial shows absolute risk reduction of 2% with ezetimibe. Cholesevelam. Bile acid sequestrants can be used as adjunctive therapy for modest LDL cholesterol loading after treatment with a statin and ezetimibe. It is a polymeric hydrogel which works by binding to bile acid to form insoluble complex that is eliminated in feces. It can lower the LDL cholesterol by 14 to 18% with potentially larger reduction to 25 to 30 even with higher doses. PCSK9 inhibitors, it provides an added benefit for patients who are intolerable to statin. Alirocumab and evolocumab are fully humanized monoclonal antibody against PCSK9. These agents act to increase available LDL receptors and further reduces LDL cholesterol level as monotherapy and in combination with a statin or ezetimibe. Lipoprotein apheresis, patient with high LDL cholesterol after maximally tolerated lipid lowering therapy can be considered for lipoprotein apheresis. Management of lipids in women with FH during pregnancy. Statins are contraindicated in pregnancy. The only drug approved for bile acid sequestrants which are not absorbed systematically and lipoprotein apheresis are recommended during pregnancy. Other drugs are contraindicated. Next to experimental lipid lowering therapies in development. Bempedoic acid is an oral small molecule that inhibits hepatic adenosine triphosphate lyase, leading to inhibition of the production of acetyl coenzyme A. It also upregulates LDLR and leads to LDL cholesterol reduction. Next is MGL3196 is a thyroid hormone receptor beta selective agonist.
Sorry for the interruption, but we'll have to sum it up in next 30 seconds.
In phase 2 trial, inhibitors of angiopoietin like 3 are being evaluated and gamvacine and inclisiran small interfering RNA directed against PCSK9 mRNA are also in phase 2 trial. Conclusion, diagnosis of FH in younger patient with multiple xanthoma is important because of the fact that they are indicators of premature atherosclerosis and leads to death from myocardial infarction. Early diagnosis and treatment and screening of family members help in lowering the risk of such complication earlier. Close follow-up and monitoring of the response and side effects of the treatment is essential in optimizing care of the patients. So, cheese, fatty. Oily food नहीं खाना है, cheese नहीं लेना है sir, cheese has having high.
हाँ, क्या मना करिएगा उसको नहीं खाने के लिए?
Sir, cheese oils.
गांव वाला लोग चीज़ थोड़ा खाते हैं, कहाँ खाते? आपका तो पेशेंट गांव का है. चलिए ठीक है. Thank you.
Thank you, sir.
Thank you so much. Moving ahead, I would like to call next speaker, Dr. Rija K. Anthony.
फर्स्ट स्लाइड इज नॉट विजिबल. ये फर्स्ट, ये सेकंड स्लाइड है. Very good afternoon to all my respected faculties and my dear friends. My name is Dr. Rija and I would like to present a case report on dengue encephalitis, which is a rare manifestation of a common disease. I would like to go through all these topics. The clinical spectrum of dengue fever ranges from asymptomatic infection to dengue shock syndrome. Neurological complications are not commonly seen in dengue. There are 5 serotypes of dengue like 1, 2, 3, 4 and 5. Dengue virus is classically considered as non-neurotropic in nature. However, in recent years, neurological manifestations of dengue have been documented. The spectrum of neurological manifestations seen in dengue has been classified into 3 categories. Those related to neurotropic effect of the virus like encephalitis, meningitis, myositis and myelitis. Those due to the systemic complications of infection like encephalopathy, stroke and hypokalemic paralysis. Finally, post-infectious complications like encephalomyelitis, optic neuritis and Guillain-Barré syndrome. Dengue encephalitis is a rare entity. Here I am going to present a case report on dengue encephalitis. Coming to epidemiology, it is the fastest spreading mosquito-borne viral disease globally, affecting greater than 100 million humans annually. Dengue also causes 20 to 25,000 deaths and is found in more than 100 countries. The primary vectors of the disease are female mosquitoes of the species Aedes aegypti and Aedes albopicus. These species of mosquitoes tend to live indoors and are active during the day. Transmission by perinatal route, blood transfusions, breast milk and organ transplantation have been reported. There are 5 serotypes of dengue virus, as I have mentioned before. The viral serotypes causing disease outbreaks have varied with time. Coming to the case, a 28-year-old female patient has come to the medical emergency room of Jalan Medical College with presenting complaints of sudden onset of altered sensorium and episodic abnormal body movements since one day. There was no loss of consciousness, but the patient was in a confused and extreme fatigue state after an episode of tonic-clonic movements of bilateral limbs which lasted for 10 minutes. Urinary incontinence was present. There was generalized weakness of the limbs. There were few episodes of vomiting, but there was no history of any trauma. Patient had a history of fever which started 1 week before the present illness, which lasted for 4 days. She was also complaining of body pain, severe headache and nausea. No history of any cough, pain abdomen, altered bowel habits, burning micturition or any skin rashes, thus avoiding other systemic infections. She had no history of any bleeding from mouth, nose or per rectum. There was no history of any chronic illness, either medical or surgical, no history of any seizures in childhood, not a known case of psychiatric disorder also. On examination, patient's vitals were stable. General examination showed no positive findings apart from mild pallor. CNS examination showed altered mental status and 4/5 grade power in all 4 limbs. Tone of the muscles normal, normal reflexes and sensory system. Meningeal signs were absent with bilateral flexor plantar response. Other systems were within normal limit. Patient was admitted in the hospital and was started on conservative management. On routine investigations and fever screening, she was found to be dengue positive. Further probing into the case led to the diagnosis of dengue encephalitis. She gradually improved over a few days, came back to normal sensorium and there was no further episodes of seizures. She was discharged after a few days of hospital stay with complete recovery. So these are the investigations, and it was showing mainly thrombocytopenia. Platelet count was 46,000 and hematocrit was towards the upper side of normal, which is 54, and she came positive for serum dengue IgM. And continuing with the investigation, NCT brain shows no parenchymal lesion particularly, but there was diffuse cerebral edema. CMRI brain shows hyperintensities in bilateral cerebral, mainly frontal and temporal lobes, and cerebellar hemispheres and thalami. CSF analysis shows pleocytosis, mainly lymphocytes. EEG shows partial seizure disorder. Treatment mainly consists of IV fluids, antipyretics, antiepileptics, mannitol injection for reducing cerebral edema, antibiotics, regular monitoring of vitals, and we were continuously monitoring for any bleeding manifestations also. Encephalitis is inflammation of the brain parenchyma, often due to viral infection. Dengue virus was earlier considered non-neurotropic, but recent observations were proven this wrong. Direct viral invasion of the CNS, possibly as a result of the blood-brain barrier reception, is a proposed pathogenesis of neural involvement. The majority of the patients with dengue encephalitis have normal findings on neuroimaging. MRI is preferred over CT head, although the findings are often non-specific. Thalamus and basal ganglia are the commonly affected sites, followed by cerebral cortex and cerebral hemispheres. Findings such as focal hemorrhage, patchy areas of diffusion restriction as post-contrast enhancement have also been defined. Eliciting dengue viral antigen or specific antibodies in CSF or viral RNA detection by PCR is conclusive evidence of dengue encephalitis. The prognosis in dengue encephalitis is good with adequate management, although the mortality can range up to 3.7%. Thus, coming to the conclusion, dengue encephalitis should be kept as differential diagnosis in patients with a short history of fever and subsequent neurological symptoms, especially in the countries where dengue is endemic. Clinicians should have a high index of suspicion since the prognosis is good and is based on timely, adequate management. Thank you.
Why did you say it's dengue encephalitis? Why not dengue encephalopathy?
Because encephalopathy, usually a clinical diagnosis where it is usually a clinical diagnosis where after episode of fever, patient will present with complaints of altered sensorium, seizures like that. But dengue encephalitis, one more criteria is added to that. If we can elicit NS1 positivity or IgM positivity in the CSF fluid, that it comes to the criteria that it will be definite dengue encephalitis.
Is it the same?
Sir, if neuroimaging like MRI shows any positive findings and EEG shows any positive findings, we'll get a proof for encephalitis. Encephalopathy is rather is in dengue itself, like in chronic kidney disease, it can lead to uremic encephalopathy. Like in liver problems like hepatic encephalopathy. Yes, sir. Because there is inflammation of the. Yes, sir. Yes, sir. Yes. Because there is a direct neuronal invasion by the dengue virus. So it can cause secondary to the systemic complications of the disease, like metabolic derangements. No, sir. Sir?
Then how do you say that virus invaded CNS or brain, whatever?
Sir, in this case, this is a probable case of dengue encephalitis, not a definitive clinical.
Why not encephalopathy? Why encephalitis? Why you are insisting on encephalitis? Why not encephalopathy?
Because, sir, because. Yes, sir, there is structural evidence for structural damage through. Sir, functional damage with structural damage leads to diagnosis.
Is there any structural damage?
Yes, sir. CEMRI shows hyperintensities in bilateral thalamic and gangliocapsular neuralgia.
No, that is not damage.
Is it the same case I had told to report? Is it that same case?
Sorry, sir?
Is it the same case which I had told to report?
Yes, sir.
Yeah, that is. So, what do you say that, did you do a LP of this patient?
So, sir, we didn't get consent from the patient party for
Yeah, I know that because he was not agreeing to it. But then why, how do you classify encephalitis with dengue? Why not encephalitis is another entity and dengue is another
Because we
entity.
could elicit IgM positivity, dengue IgM positivity in serum.
In serum it was.
Yes, sir. IgM positive. Dengue IgM positive.
Did you do that?
Yes, sir.
For the CSF?
Thank you so much. Moving ahead, I would like to call our next speaker, Dr. Shouvik Chatterjee. Meanwhile, I would like to announce the name of next three speakers, Dr. Ravikant Kumar, Dr. Saif Iqbal, and Dr. Tahsin Fatma.
Good evening, everyone. I am going to present a case of tropical pulmonary eosinophilia. Tropical pulmonary eosinophilia is a syndrome of wheezing, fever, eosinophilia seen predominantly in the Indian subcontinent and other tropical areas. Its etiological link with Wuchereria bancrofti and Brugia malai has been well established. The pathogenesis is due to an exaggerated immune response to the filarial antigens, which include a type 1, type 3 and type 4 reactions with eosinophils playing a vital role. In India, TPE is most commonly found in coastal regions of Maharashtra to Kerala and West Bengal to Tamil Nadu. The prevalence in India varies from 0.5% among children in Tamil Nadu to 9.9% among jail inmates in Patna. My patient, age 44 years, male, a retired pharmaceutical company manufacturing unit worker, presented to me in the OPD with complaints of cough with mild expectoration since 3 months, fever on and off since last 3 months, breathlessness on exertion since last 3 months. Patient was apparently asymptomatic 3 months back. Then he developed mild expectoration. Cough was insidious in onset and progressive in nature. Expectoration was white, watery, and 1 to 2 TSF in volume. There was no offensive odor, nor did the volume of expectoration vary with posture. There was no diurnal variation of cough. The patient had fever alongside the cough. It was intermittent, moderate grade without chills and rigor. Patient had SOB on exertion since 3 months, MMRC grade 2. There was no diurnal variation, and the SOB was predominantly present when the patient had bouts of coughing. No history of orthopnea, PND. However, the patient did complain of anorexia or weight loss, and there was generalized weakness. No significant past history. No significant personal history except for being a smoker 12 years back, but currently claims to have left smoking since last 12 years, and he has always been non-alcoholic. Treatment history: patient took over-the-counter medications for a couple of weeks for his cough and fever with no relief of symptoms. Then he visited a nearby hospital where he was started on ICS-LABA combination based on his symptoms. He was also ordered an HRCT. The patient took the ICS-LABA combination as a PMDI for a couple of months, and on follow-up visit to the same hospital, his HRCT was assessed and was diagnosed as pulmonary COX with initiation of antitubercular drugs. The patient then came to our OPD as he wanted to sought a second opinion regarding the initiation of his antitubercular drugs. No history of any drug intake for any chronic illnesses. Nothing significant family history, no significant allergy history. General examination was within normal limits, BP being 170, pulse 78 per minute, and respiratory rate 14 per minute. Systemic examination was unremarkable in inspection, palpation, percussion, and in auscultation there were bilateral crepitations heard over infrascapular, infraaxillary, and inframammary areas. Occasional rhonchi were heard over the infrascapular areas. Bilateral air entry was equal with normal vesicular breath sound. Vocal resonance was bilateral normal. This was the HRCT. Zooming on the lung window, the reporting said there were multiple tiny centrilobular nodules diffusely scattered equally in bilateral lungs, suggestive of miliary tuberculosis. This was the initial blood reports with urea creat being normal, liver profile being normal. However, there was a WBC count of 30,520 with a eosinophil differential of 75.1% and an absolute count of 22,930. ECG was normal. The sputum CBNAT was MTB not detected. Serum IgE was more than 1,000. Filarial antigen was positive. IgG filarial antigen was positive, basically detected. Stool examination was unremarkable. Spirometry showed obstruction with restriction with no post-bronchodilator reversibility. Patient was initiated on diethyl carbamazine citrate at 6 mg per kg body weight for 14 days. The next slide shows his CBC report after 16 days. We can see, hello. We can see the eosinophil count has significantly reduced to 11.9%. At this stage, 10 mg prednisolone was added.
Time is up. So, if you could conclude.
Yeah, just 30 seconds.
Okay.
At this stage, 10 mg prednisolone OD was added as it was a chronic case, and finally we see the eosinophil count to be at 2%. And this is the diagnostic criteria for tropical pulmonary eosinophilia and the treatment. Thank you.
Thank you.
What was your chest X-ray finding before CT?
Chest X-ray findings, sir, there were bilateral reticular opacities with miliary distribution of nodules.
What is the difference?
Looking at the chest X-ray and HRCT before performing the blood test.
Chest X-ray.
Only the chest X-ray. So, looking at the presentation and the chest X-ray, my first differential was miliary tuberculosis, and then we also thought of some fungal infections, and this was our basically the initial.
Which drug leads to this type of picture, chest X-ray?
Sir, yes, sir. Sorry, sir, I'm unable to.
No problem with that. I think we'll have to move to the next one. We have Dr. Ravikant Kumar as well. Can I request Dr. Ravikant Kumar to please take the dais? Thank you so much, sir. Thank you.
Good evening, sir. This is Ravikant Kumar, Medicine PG second year from JLMC Bhagalpur. I will be presenting a case presentation on systemic sclerosis. My patient name Ghurtas Tati, 30 years male, resident of Gangania, Sultanganj, came to JLMCH emergency with chief complaints of difficulty in opening his mouth since 2 years, fever with multiple joint pains since 3 months, and dry cough since 3 months. He presented with difficulty in opening his mouth and atrophy of bilateral fingertips. On query, he mentioned that he is suffering from this problem from last 2 years and it is progressive in nature. He also noticed that his skin of hands and other parts of the body becoming very tight so that he cannot sit for the toilet. He also complains of multiple joint pain since 3 months, which was gradual in onset, symmetrical and progressive in nature, no aggravating factor, relieved on taking NSAIDs and associated with morning stiffness and fever, which was low grade, relieved on taking paracetamol and doing household activities. He also complained of dry cough since 3 months, which was gradual in onset, not associated with sputum production, relieved on cough suppressants. No history of pulmonary TB, hypertension, diabetes mellitus, alcohol or smoking or any similar family history. He is taking non-veg diet, his bowel bladder habit is normal, taking cough suppressant and PCM for cough and fever respectively. On examination, mild pallor, no cyanosis, clubbing, icterus, edema. On examination, the skin of his face reveals smooth, tight, mask-like appearance and microstomia. Bilateral PIP, DIP, MCP wrist joints were swollen, not associated with any deformity. On palpation, they were tender and warm, no involvement of the spine. On CNS examination, patient is conscious, oriented to time, place and person. All heart sounds are heard normally in their respective areas. No murmur heard. All quadrants moving equally with respiration. No ascites or organomegaly is found. Trachea was in midline and bilateral diffuse fine inspiratory crepes were present. On routine investigation, hemoglobin was 9.1, KFT LFT within normal limits, ESR and CRP were raised, uric acid RA factor ASO titer was normal, viral markers were negative, chest X-ray shows bilateral diffuse interstitial pattern, HRCT chest shows patchy areas of consolidation or ground glass opacity scattered within in the both lungs. SCL70 was positive, UN-RNP positive, ANA positive, nuclear intensity 3+, HLA-B27 was negative. Considering all the above features, we come to final diagnosis of scleroderma. This patient was given tab methylprednisolone 40 mg OD and hydroxychloroquine 200 mg with other supportive treatment and followed up. This shows the pathogenesis. Pathogenesis lies within the injury within the small blood vessels, which causes hypoxia and ultimately it leads to TGF beta stimulation and causes fibrosis and collagen deposition in the skin and connective tissues. Scleroderma is a multi-system disorder. Autoantibody profile will help in identifying disease severity. We should be more attentive to the potential risk factor. Treatment should be initiated as soon as problems are identified.
Yes, I believe.
What is the so-called medical management in systemic sclerosis? Medical management.
Sir, we all start with first oral steroids, sir, methylprednisolone, and other DMARDs can be used, hydroxychloroquine, and if ILD is suspected, we can start with mycophenolate mofetil, cyclophosphamide.
क्या लगता है? Do you feel कि medical management is helpful?
Sir, no. It helps in relieving the symptom, but not helps in curing the symptoms.
What is the incidence in our area? How many cases so far you have seen in JLNMCH?
Sir, I have seen one case.
Incidence is quite high.
Yes.
Incidence is quite high. Thank you.
Thank you so much. Our next speaker is Dr. Saif Iqbal. I request him to get started. Thank you. Dr. Saif, you can get started.
Very good afternoon, everyone. I am Dr. Saif Iqbal, a postgraduate resident, second year from Department of General Medicine, Narayan Medical College, Sasaram. Today's discussion will be on atrial fibrillation. Atrial fibrillation is the most prevalent persistent cardiac dysrhythmia in the world with an increasing frequency. In addition to producing severe symptom load, AF is a major cause of morbidity and mortality due to risk stroke that comes with it. Cardioembolism appears to be a prominent contributor in AF-related stroke, despite the fact that the complete causal pathways are still being investigated. AF is the most prevalent cardiac arrhythmia, accounting for 1/3 of all the arrhythmia-related hospitalizations. Ischemic stroke is one of the most worrying complications of AF, with an annual incidence of roughly 5% in the absence of effective prevention. Different types of AF, which we are going to discuss here, is there are valvular and non-valvular. AF that isn't caused by a mechanical heart valve or moderate to severe mitral stenosis is known as non-valvular AF. Chronic non-valvular AF is associated with a 4.5% annual risk of thromboembolic consequences. Age, previous stroke or acute cerebral ischemia, diabetes, hypertension and left ventricle dysfunction are all known risk factors. Oral anticoagulation therapy with warfarin has been shown in placebo-controlled trials to be efficacious for primary and secondary prevention of ischemic stroke, reducing risk factor by 68%. Atrial fibrillation has been linked to a hypercapillary state in both paroxysmal and chronic atrial fibrillation, according to several investigations. Furthermore, increasing plasma concentration of platelet activation markers, beta thromboglobulin, platelet factor 4, and soluble preselectins, thrombogenesis markers, thrombin, antithrombin complexes, and evidence of endothelial dysfunction and damaged von Willebrand factor have been shown to be independent correlates of thromboembolism. AF-related strokes are more often fatal or associated with greater permanent neurological deficit than strokes from other causes, but they can be effectively prevented with oral anticoagulation therapies with well-controlled vitamin K antagonists or non-vitamin K antagonists, oral anticoagulants such as Epic-7, Rivaroxaban, Dabigatran, and Endoxaban. Aim of the study which I did was to study the prevalence of use of anticoagulants in the treatment of non-valvular AF. Material method study group was the patients of non-valvular atrial fibrillation admitted in the medicine department visiting medicine OPD of an MCS. Study design was cross-sectional observational study. The study period was for 10 months on 180 patients. Inclusion criteria were all willing patients of 18 years of both sexes with diagnosis of AF of non-valvular etiology, and exclusion criteria was patients with a diagnosis of AF with incomplete records were excluded and those who were not given the consent. Methodology was cross-sectional observational study on patients with non-valvular AF who were hospitalized in medicine ward or visited medicine OPD at NMCH over a period of 10 months. Non-valvular AF patient were defined as AF patient without rheumatic fever, disease, predominantly mitral stenosis or mechanical heart valves. So what we did in our study was data was regarding patients' demographics, comorbidities, and patient were diagnosed for AF will be recorded, and Chadwick score and Hasselblad score were recorded for each patient. And the records were analyzed for use of anticoagulation and antiplatelet drugs. If they are found to be on AC or AP, their INR will be analyzed from previous report to know about the TTR. For ease of simplicity, we will use traditional methods for TTR calculation. Here is the Chadwick score by which we will calculate, and the Hasselblad score. Statistical analysis is continuous variables were expressed and mean, while categorical data were summarized as frequencies and percentage of patients. The predictors for prescribing NOACs during hospitalization were developed by univariate analysis. The p-values were two-sided. All willing patients over 18 years of age of both sexes with a diagnosis of AF or non-valvular AF etiology. What we did in the study was 180 patients were taken. Out of 45 had a Chadwick score less than 1. 135 subjects had more than 1. So we'll take these 135 subjects in this study, in which we'll see the percentage of cases in which the score will lie. And we'll also see the distribution of patients with non-viral AF according to risk factors used in the Chadwick scale. Out of 135 eligible patients, only 13 were on anticoagulants. In patients who received anticoagulation, the average points of score was 3.5. And who hadn't received anticoagulation, the most common risk factors was hypertension. Distribution of patients with non-viral AF according to risk used in Hart's blood score. The bleeding tendencies were maximum in patients of age more than 65 years. Conclusion: in spite of all the guidelines advocating use of anticoagulants as per Chadwick score and bleeding risk, has led very few non-viral AF patients in rural India are being put on anticoagulants. Number of cardiologists are very low in this setup, so more focus should be put on family physicians to these areas to evaluate and prescribe required drugs in these patients. We have references. Thank you.
Dr. Saif, how did you diagnose it to be a case of non-valvular atrial fibrillation? In short, how did you diagnose it to be a case of non-valvular atrial fibrillation?
So in our setup, we have present the echocardiography, and also we have TEE, by which we diagnose that the valves are involved or not, whether any rheumatic origin is there or any mitral stenosis is present or not.
So in valvular AF, you get a different echo finding.
Yes, sir.
Why?
So there will be valvular AF, the valves will be...
Because involvement of the mitral valve.
Mitral stenosis will be there, mitral regurgitation will be there.
M pattern will be there.
Yes, sir.
Okay.
Yes.
Now you started with warfarin.
Yes, sir.
What is your idea? How much to keep the PTINR?
So between 2 to 3.
Suppose you have given warfarin and it has gone to 6. What will you do?
So we'll taper off the dose.
How?
So we'll taper off the dose.
There is a proper schedule for reducing as well as increasing the dose, keeping the INR with a maximum of 2.5 IR.
Yes, sir.
Okay? Thank you.
Thank you, sir.
Thank you.
Thanks to our speaker. Moving to next, I would like to request our next speaker, Dr. Tahseen Fatma, to please join us on the dais. Meanwhile, I would like to mention the next 3 speakers as well. Dr. Mona Suman and Dr. Shubham Oja.
Good evening, everyone. Myself, Dr. Tahseen Fatma from Nalanda Medical College and Hospital. Introduction part. The systemic sclerosis is an orphan disease of unknown etiology, complex pathogenesis, and variable clinical presentation. It frequently follows a progressive course and is associated with significant disability and mortality. The early stages of systemic sclerosis are associated with prominent inflammatory features, but over time, structural alteration in multiple vascular beds and visceral organ dysfunction due to fibrosis and atrophy progressively dominate the clinical picture. There are 2 subsets of systemic sclerosis: limited cutaneous systemic sclerosis and diffuse cutaneous systemic sclerosis. Involvement of skin. In limited cutaneous systemic sclerosis, skin vomit is indolent in onset, limited to fingers and distal to elbows, first, and involve the face and has slow progression. In case of diffuse cutaneous systemic sclerosis, it has rapid onset, it involved diffusely and involved fingers, extremities, face and trunk, and has rapid progression. Raynaud's phenomenon. In case of limited cutaneous systemic sclerosis, it antedates the skin involvement, may be associated with critical limb ischemia. In case of diffuse cutaneous systemic sclerosis, it has coincident with the skin involvement, and critical limb ischemia is less common. Interstitial lung disease involvement in limited cutaneous sclerosis is slow progressive and generally mild. But in case of diffuse cutaneous systemic sclerosis, it is frequent and early onset and can be severe. Pulmonary artery hypertension in case of diffuse limited systemic sclerosis is frequent, late, and may occur as an isolated complication. But in case of diffuse, it is often associated with it is often occurs in association with interstitial lung disease. Musculoskeletal finding, it is a mild arthralgia, but in case of diffuse systemic sclerosis, it is severe arthralgia with carpal tunnel syndrome and tendon friction rubs. Calcinosis cutis is more frequent and prominent in case of limited systemic sclerosis, and autoantibodies involved in limited systemic sclerosis anti-centromere antibody, and in case of diffuse systemic sclerosis it is anti-topomerase I1 and anti-RNA polymerase 3. Case report. My patient Miss Yusha Devi, 45 years old, Hindu married female, wife of Raj Kumar, resident of Nalanda, Patna, came presented with complaint of difficulty in breathing on exertion, chest pain, tightening of skin of both lower limb and upper limb and face, and itching in the affected area, and unable to open the mouth fully, difficulty in swallowing of liquid and solid food, multiple joint pain with limitation mobility of fingers and wrist joint, whitish pigmentation of skin of limbs and nape of neck, and episodic pain in digit on exposure to cold water. These are the images. History of presenting complaint. Patient was apparently well 1 year back. First she noticed tightening of skin which first developed in the fingers of upper limb bilaterally. Then it progressed distally from finger to upper arm. Then involved the skin of face and skin of lower limb bilaterally. She also complained of dryness of skin and itching. Gradually patient also noticed loss of wrinkling over the face. There was episodic pain in the distal phalanges of fingers and toes on exposure to cold water which developed simultaneously with skin involvement. There is pain in multiple joints involving back since 7 to 8 months with limitation of mobility of fingers and wrist and some extent to elbow joint too. There is no history of morning stiffness. By the time patient present to us, there were a flexion deformity of fingers and wrist also developed. There is widest pigmentation of skin of both upper and lower limb and nape of neck since 4 months. We show the widest pigmentation on the dorsum of the hand. There was difficulty in opening of mouth fully at presentation. She was able to open her mouth only up to 2 finger breadth. She also complained of dyspepsia and dryness of mouth. With progression of time, she had difficulty in chewing and swallowing of both liquid and solid food. The shortness of breath on exertion, grade 3 since 6 months, which was progressive nature. There is no history of orthopnea, proximal nocturnal dyspnea. It was not accompanied by wheeze. There is episodic dry cough with no diurnal variation and seasonal variation since 1 year. This macrostomia, salt and paper appearance of skin and hardening and tightening of facial skin as shown. Past year, there was no history of diabetes, mellitus, asthma and any chronic illness, and family history, there is no history of similar illness was present in any member of the family. Personal history, there is nothing significant. General examination, patient was conscious and well oriented with respect to time, place and person. There was no pallor, ectasia, cyanosis, clubbing and lymphadenopathy. All the vitals were within normal limit. Chest on auscultation was inspiratory crepe present at lung. Heart sound was audible and there was no murmur. Scene examination was within normal limit. On inspection, her skin was tough, shiny and whitish pigmentation present on the dorsum of hand and arm and leg. Her oral aperture was small, mask-like face with reduced blinking and loss of wrinkling. Flexion deformity present in the fingers of upper limb and wrist. Lab investigation, her serum anti-topomerase I1 antibody was 118 unit. Her HRCT chest report is sensitive of the interstitial lung diseases. On TDOCO, there is a concentric LVH with no feature of pulmonary hypertension, and PFT show the restrictive pattern. This was her report. Result treatment given based on the history, clinical picture, examination, lab work. We come to conclusion that this was a case of diffuse cutaneous systemic sclerosis. She was given prednisolone 50 mg once daily for 1 month, which was tapered down gradually over the period of 6 months, which with follow-up with all routine investigation every 14 days. She was started on injection rituximab 500 mg. And prior to administration of rituximab, we have her Montu test, HbS-Ag, anti-HCV was negative. She was also prescribed tab nintedanib 150 mg twice with reviewing her HRCT report and PFT report. She was prescribed tablet Remipril for the proteinuria after reviewing her immunity SCR.
Sorry for the interruption. Yeah. Okay.
After giving steroid daily for 6 months, once a month rituximab therapy for 6 months, patient system improved significantly. She is not able to open her mouth up to 4 finger breadth and her skin tightness also reduced. This can demonstrate that combined treatment with steroid, rituximab, nintedanib result in beneficial treatment against the diffuse systemic sclerosis, and patient is also encouraged to do physical therapy for improvement in available range of motion and joint protection.
What was the treatment?
So we have first given the low dose oral steroid, prednisolone, for the joint tenderness, and then we have Then sir, we have started cyclophosphamide, but after that her urinary SCR start increasing. Then we have to stop it. Then we started sir injection rituximab 500 mg once a month for 6 months sir. After giving this treatment sir, her oral she was able to open her mouth sir up to 4 finger breath. Her shortness of breath and chest complaint was significantly improved, and patient doing very well sir.
Okay, thank you.
Thank you sir.
Hello. I would like to request our next speaker, Dr. Mona Suman.
Good evening, everyone. I, Dr. Mona Suman, from Narayan Medical College in Sasaram, postgraduate student from Department of General Medicine. I have comparative study on acute myocardial infarction in young patient less than 45 years in comparison of old age patient 45 years or more. Coronary artery disease is a devastating disease precisely because an otherwise healthy person in the prime of life may die and become disabled without warning. When the affiliated individual is under the age of 45 years, these incidents are very frustrating for families, friends and occupations. These young patients also have a different risk factor profile, clinical presentation and progression in comparison with older patients, and has been taken into consideration when treating these young patients presenting with myocardial infarction. Better prognosis among the young adults is achieved when an appropriate investigation and treatment are offered. In developing countries, coronary heart disease are subject of concern. It is expected to be a single most important cause of death in India by the year 2015. CVDS has been attributed to the maximum proportion to the total medically certified death for around 30%. Further, among cardiovascular disease and coronary heart disease has contributed to around 1/3 of the mortality, with more death in males 64% and that too in economic productive age group of 30 to 69 years. Materials and methods. Source of data. The present study will be conducted on patient admitted in intensive care unit, Department of Cardiology, Narayan Medical College, and sample size taken is 25 patients from Group A and 25 patients from Group B. Group A is less than 45 years and Group B is greater than 45 years or more. Study design is cross-sectional prospective studies. Duration of studies from December to September 2023. Inclusion criteria: patient with the diagnosis of acute myocardial infarction, patient with the first episode of acute myocardial infarction, and study included both sex. Exclusion criteria: patient with the subsequent acute myocardial infarction and those patients who refuse to give consent for the study. Methodology: patient with the diagnosis of acute myocardial infarction, young patient less than 45 years of age group, and older patient greater than 45 years of age group. Variables used in the study of demographic categories are age, sex, clinical spectrum, family history of heart disease, coronary risk factor, hypertension, smoking, dyslipidemia, diabetes mellitus, lifestyle, eating habits, family history. Diagnostic procedure: CBC, RFT, LFT, ECG, and 2D echo with lipid profile and RBS with cardiac enzymes and chest X-ray. Therapeutic procedures: pharmacological therapy and developing complications and outcome. Statistical methods are used by the chi-square and with the statistics result. In the cross-sectional prospective studies, we have studied 25 patients of age less than 45 years with a diagnosis of acute myocardial infarction and a comparative with patient with same diagnosis of age 45 or more. In this study, a group A mean age was found 36.98 years and in group B mean age was 60 years old. These are the different variables in both age group. Males 92% and in females and in males older than 45 years are 80%. Female having 8% only in group A and in group B 20%. Most common is the chest pain associated with group A person, and rest are the remaining categories like current smoking, overweight, dyslipidemia, mild to moderate left ventricular dysfunction, overall mortality. These are the different variables in both age groups as shown in the chart. We have studied 25 patients of age less than 45 with a diagnosis of acute myocardial infarction and compared with the patient of age 45 years or more with the same diagnosis. Myocardial infarction in the male are more common in both age group, but in elderly patient, the number of female patients were increasing. Most common symptoms were chest pain in both the age group, followed by breathlessness, giddiness, but in group B, patient breathlessness present about half of the patient. Most common clinical presentation was in form of STMI and anterior wall MI, the commonest. In our study, current smoking, dyslipidemia, and overweight found to be a significant risk factor for myocardial infarction in young patient, but in group B hypertension was the most common risk factor was dyslipidemia. Thank you.
What did you find? What was the difference between the old and the young?
Sir, young patient basically, in young patient, basically who are the chronic smokers are more likely to be having a risk factor for the acute myocardial infarction. And in the old patient who are more like dyslipidemia, diabetes mellitus, or prolonged hypertension are more likely with the major cause for acute coronary disease. Prognosis is very better in young patients, sir. Young patient, yes, sir.
Hello.
Thank you, sir.
Thank you so much. Moving ahead, I would like to request our next speaker, Dr. Priyesh Pranav.
Good afternoon, everyone. My name is Priyesh Pranav. I am second year medicine PG in JRMCH. My case is a case of inherited muscle dystrophy. History. My patient, Abdullah Adil, 30-year-old Muslim male, is a resident of Brahpura, Bhagalpur. Date of examination was 6 October 2023. The patient is not employed. Presenting illness, there was a complaint of progressive weakness in bilateral lower limb and upper limb. History of presenting illness. The patient was apparently symptom-free 27 years back. Then he started falling backwards during walking. Further, he developed difficulty in getting up from sitting position or lying down position. While getting up from lying down position, he used to roll over his body and then take support successively on ground, feet, legs, knees, waist, and then he finally stood up. Gradually, his speed of walking decreased and he started walking on toes with a history of repeated fall during walking. His condition led to limitation of daily activities. Further, he developed contractures in bilateral lower limb 25 years back. Weakness of bilateral arms started 14 years back. Weakness started proximally and difficulty in daily activities like combing hair, and progressed to difficulty in taking food from plate to mouth, and further passing of objects to another person. All these weaknesses are not associated with any sensory loss. Also, there is no abnormal sensation in all four limbs. Weakness is not associated with any autonomic neuropathy like bowel and bladder involvement. There is no diurnal variation in weakness. Weakness is progressive in nature. There is no myalgia, no cramps, no myotonia, no ptosis, no dysarthria, no facial muscle weakness, no baldness, no scapular winging. Back muscles are normal. There is a family history with patient's elder sister and paternal and suffering from the similar illness. As a child, the patient was vaccinated. There is history of fractured left femur in 2015 for which intramedullary nail was placed. There is a history of fracture of left tarsal bone in year 2022. Patient was diagnosed with diabetes around 3 months back, for which he is taking metformin 500 mg once daily. Family history and personal history. There is no history of similar illness in the family. There is history of similar illness in the family. However, there is history of consanguineous marriage in family with patient's mother and father being first cousins. Father is non-vegetarian by diet. Patient is non-vegetarian diet, and there is no history of addiction. Patient is conscious oriented to time, place, and person, intelligent and lying in bed in supine position with his legs in partially flexion, adduction, and internal rotation. Patient is average built with average nutrition. There is no pallor-icterus edema, clubbing, cholinergia, cyanosis, and lymphadenopathy. Temperature is normal. Pulse is 76 per minute. Regular rhythm, normal in volume, catacrotic in character with no radiofrequency delay. Condition of arterial wall is normal. Blood pressure 124/72. Respiratory rate 18 per minute. Systemic examination. Examination of respiratory system, cardiovascular system, abdominal system are within normal limit. Sinus examination. Heart function. Patient conscious, alert, cooperative, oriented to time, place, and person, intelligent and intact, past, present, and immediate memory. There is no apparent deformity of cranium and spine. There are no signs of meningeal irritation. Examination of cranial nerves are within normal limit. There is atrophy of both lower limbs and upper limb. Upper limbs are lying in extension with arms and hands partially pronated, fingers flexed. Lower limb lying in partial flexion at hip joint and knee joint with attraction of the hip joint. Hypotonia is present in both upper and lower limb. There is no visible involuntary movement. Coordination and gait could not be tested. Power. Power in upper limb, left and right arm at shoulder joint is abduction present up to 15 degree, which is power is of grade 2. Adduction, flexion, extension, power is of grade 2. At elbow joint, flexion, extension, medial and lateral rotation. In all motion, power is of grade 2. Wrist joint, power is of grade 4. In lower limb, hip joint power is grade 0 in flexion extension, grade 2 in adduction and extension. Knee joint, grade 3 in medial and lateral rotation. Ankle joint power in all movement is grade 4. Reflexes or superficial deep reflexes absent. Examination of sensory system. Examination of sensory system is within normal limit. There is no bladder or bowel involvement. Investigation, muscle biopsy showed depleted muscle fiber preparation, variable size of fibers, clustering of small fibers, prominent nuclei, increased fat cells, increased endomyosial fibers. CPK level were 259 units per liter. 2D echo shows no evidence of cardiomyopathy. Genetic testing was positive for RYR1 mutation. Provisional diagnosis, this is a case of cardioparesis due to lower motor neuron lesion, probably due to limb girdle muscle dystrophy. There is no known treatment of these conditions, so patient was managed conservatively on physical therapy and rehabilitation therapy. This is a figure showing different muscle, different proteins that are involved in different kind of muscle dystrophies. Thank you. Yes. Yes, sir.
Your subject is muscular dystrophy.
Yes, sir. Yes, sir.
And you told that the reflexes were absent.
Yes, sir. Reflexes were absent.
Why?
So in advanced cases, all the muscles, all the reflex arches become degenerated. Muscles become degenerated, so reflex arches become degenerated, and the reflexes are absent in advanced cases.
So the defect in muscular dystrophy leading to absent jerk.
Yes, sir.
Is at which place? Muscle won't let you. It will be sluggish.
Yes, sir.
If the lateral column is involved, it will be exaggerated.
Yes,
but
sir.
why absent? Is there some sensory involvement as well?
No, there is no sensory involvement, sir.
Then how it went off?
Sir, the innervation is lost, sir. Alpha motor neuron innervation is lost, which reflex arc is disturbed, sir.
Okay. Thank you.
Thank you, sir.
1 minute.
Sir.
What's the cause of death in these cases?
Sir, most common cause, if it is a decaying muscular dystrophy, the most common cause is respiratory paralysis. Thank you.
Hello. I would like to request our next speaker, Dr. Shubham Ojha.
Yes, sir. Sir, screen is not coming, sir. Slides are. Yes, sir. One there.
Hello. Meanwhile, I would just like to announce the names of the next 2-3 speakers. After Dr. Shubham Ojha, we have Dr. Sangeeta, Dr. Kundan Kumar, and Dr. Piyush Ratan. After Dr. Piyush Ratan, we have Dr. Anupam Ray, Dr. Rahul Raj Mishra, Dr. Nitish Kumar.
Respected everyone and good evening. I am using this stage to present a rare complication of dengue fever which I encountered during my daily rounds. Myself, Dr. Shubham Ojha, and my guide was Dr. Rajkamal sir. This dengue fever is now affecting so many people, like 2.5 billion people are getting affected every year, and so are the complications which we are encountering day by day. So one of the complications which I encountered was dengue meningoencephalitis, which I am going to present it today. This is a case of a 21-year-old female. She is a college student in BHAGALPUR only, and coming from an economically weak family, and there is no previous family history. She is having a complaint of fever since 7 days and loss of consciousness since 1 day. She was getting treatment from a private hospital and later was referred to our hospital for better management. There was no myalgia, arthralgia, bleeding manifestation, cutaneous rash or any similar complaints. On the initial examination, the vitals of the patients were normal, but the patient was febrile with 102 Fahrenheit. CNS examination, the signs of meningeal irritation like Kernig's-Brzezinski were positive, and the patient was unconscious, and there was abnormal twitching movements which was seen near the angle of the mouth, suggestive of a seizure. So a provisional diagnosis of meningoencephalitis was made. Her lab investigation, the initial malaria test and a complete CBC and other biochemical analysis were non-contributory, and CT scan also didn't show any abnormality. We tested the blood sample which was tested positive for dengue fever, and eventually we did CSF for the patient, and we found a picture of viral meningitis including ELISA IgM positive for dengue. We interpreted as she was managed conservatively with IV fluids and antipyretics and a steroid dexamethasone 4 mg twice a day and injection level tracitam. The fever subsided on 10th day and patient gained consciousness by 11th day. She was successfully discharged without any neurological complication on 14th day of admission, and she did well on the follow-up, and repeated titer for IgM against dengue after 5 weeks was also shown to increase. My conclusion was, our report demonstrated that meningitis with or without meningoencephalitis can be first manifestation of dengue infection in endemic area. In endemic area especially, the dengue, it should be considered, meningitis should be considered as a possible etiology of meningitis, and regular monitoring of platelet count as well can be invaluable in diagnostic screening tool, especially CSF examination can be done to confirm this case. And this is additional information chart that I have put, which is according to the guideline dividing the patient into mild, moderate and severe dengue fever. And this is the guideline directed treatment for dengue fever, which is mainly based on IV fluids, crystalloids and blood transfusion. Thank you, sir. Thank you, sir.
Shubham, what are the other neurological manifestation in dengue?
Other neurological manifestation. Sir, patient can present with seizures.
Neurological manifestation in dengue.
Yes, sir.
अभी तो एक बता के गया, रीजा.
Sir, it can present as meningoencephalopathy. Encephalopathy symptoms can be there, sir.
बहुत सारा है.
Yes, sir. Guillain-Barré is possible, sir. It's a possible complication, sir.
Complication है एक neurological complication.
Cranial nerve, 6 nerve palsy can be there, sir, in dengue fever.
अच्छा, steroid is indicated in your meningoencephalitis or not?
Yes, sir, it is indicated, sir.
And what about dengue?
Dengue, it is avoided. Steroid is avoided, but for this case we have given because I was more concerned for other complications like meningeal adhesions and all, so I gave to the patient.
Thank you so much. Moving ahead, I would like to request our next speaker, Dr. Sangeeta.
Good evening, all my respected teachers and my colleagues. I am going to present a case report on myxedema psychosis, exploring the link between hypothyroidism and neuropsychiatric symptoms. A case report. My patient is 30-year-old female patient. Okay. Yeah. Okay. My patient is 30-year-old female who is housewife by occupation and with poor socio-economic conditions. She belonged from Bhagalpur. Her chief complaints was altered behavior, unable to recognize family members, lethargy, hoarse voice, facial puffiness for 1 month. History of presenting illness. Patient presented with complaint of altered behavior, unable to recognize family members, facial puffiness for 1 month. Patient was kept on antipsychotic medications during treatment at local hospital since last 1 month, but no improvement was seen in patient condition with the treatment. During hospital stay, patient had aggressive behavior episode of physical fights and usage of abusive words with nearby patients, and defecation in open and decreased sleep. She had no history of fever or no rash was found. She had no significant history of chronic illness. Her past surgical history was nil. She has decreased sleep and decreased appetite and menorrhagia since last 4 months. She had no history of any substance abuse and no drug history was found. She was taking antipsychotic medication since last 1 month, and her family history was nil. On physical examination, her build was normal, nutrition was proper with puffy face, and skin was dry, and the overall look was dull, neck was soft, and the patient was conscious, irritable, and not following the commands, and aggressive at times. Pallor was absent, edema was present, and it was bilateral non-pitting edema. With icterus clubbing and cyanosis was absent. And her vitals were BP 124/90 with diastolic being in the higher range, and pulse rate was 68, saturation within normal limit. And rest all chest, CVS, and abdomen were no abnormality found. And on CNS examination, her ankle jerk reflex was delayed with delayed relaxation. So on the basis of her clinical symptoms and the history, we came to diagnosis maybe it is a case of schizophrenia, and because of the look of the patient and on our examination finding, we also thought about if she was having hypothyroidism. So we investigated her on hypothyroidism line also. On investigations, her hemoglobin was 9.8, and her KFT and LFT was within normal limit. Her serum electrolytes were normal, and TSH being 100 milli-international unit per liter, and T3 being 2.0, T4 0.6, and USG thyroid was normal. Her ECG and chest X-ray were normal, and lipid profile was deranged. Based on her clinical profile and the investigation, we come to diagnosis of primary hypothyroidism with mixed edema psychosis. This patient was kept on tab risperidone 2 mg OD, and tab thyroxine was started with the 100 microgram OD was given, and significant improvement in the patient condition was seen in about a week, and patient's neurological symptoms were significantly improved. Patient was discharged in quite better condition. She was discharged on tab thyroxine 100 microgram OD. During the follow-ups, thyroid function was within normal range. So with this case report, I would like to highlight that in India, hypothyroidism is very common, being the prevalence being 11%, and the prevalence of mixed edema psychosis is less than 5%. But due to symptom overlap, some patients go undiagnosed, and unnecessarily they are kept on antipsychotic medications only, and no improvement in patient condition is seen, and maybe later on they end up with more dangerous conditions like mixed edema coma, whose mortality, which mortality is like 40 to 100%. So with better clinical judgment, we can easily diagnose this rare, potentially debilitating condition and manage it with prompt intervention. Thank you.
What suspicion did you have before diagnosing it to be a mixed edema psychosis? What psychotic symptoms did she have?
Sir, she was having delusions, and her behavior was very aggressive, and like she was defecating in open spaces and abusing the nearby patients, and she was not recognizing her family members.
This was the first time she was diagnosed to be a case of hypothyroidism?
Yes, sir. She had no history of hypothyroidism.
Okay, okay.
Yes, sir.
What are the other features of mixed edema, clinical?
Sir, clinically, mixed edema, there is due to...
In that patient, in the patient?
Sir, only bilateral pedal edema was found, sir. Non-pitting.
Pitting or non-pitting?
Non-pitting, sir.
Okay.
Yes, sir.
And there was no bradycardia?
Sir, her heart rate was 68, sir.
68 was there?
Yes, sir.
Okay.
With ECG being normal, sir.
7.
Thank you, sir.
Thank you so much. I would like to request our next speaker, Dr. Kundan Kumar, to please join us on the dais.
Good evening to my judges, seniors and respected colleagues. I am presenting case on pulmonary embolism masquerading as severe pneumonia. I am second year medicine PG General Institute Bhagalpur. My guide is Dr. Obed Ali sir and co-guide is Dr. Anand Sinha sir. My patient X was 20-year-old female patient, housewife by occupation, poor socioeconomic condition and was from Godda, Bhagalpur. Her chief complaint was breathlessness since 8 days, bilateral pedal edema since 8 days, weakness since 8 days, fever since 4 to 5 days and cough since 4 to 5 days. Patient was presented with complaint of breathlessness since 8 days, bilateral pedal edema, weakness since 8 days, fever and cough since 4 to 5 days. Patient was 4 months pregnant with history of abortion 10 days ago. History of dilatation and curettage done 8 days before. No active pervaginal bleeding was present. No pain abdomen and no vomiting was present. Patient has no history of diabetes mellitus, hypertension, TB, asthma or other chronic illness. Dilatation and curettage were done 8 days ago. No other surgical history was present. In personal history, she was housewife by occupation, non-vegetarian, normal sleep pattern, normal bowel and bladder movement, no history of drug allergy, no history of substance abuse. In obstetrical history, she was gravida 2, para 1 with 1 abortion. Her family history was nil. In physical examination, general condition was normal build, nutrition proper. Patient was conscious, oriented, time, place and person, febrile. Vitals were BP 98/60, pulse rate 122, SpO2 was 95 with oxygen. Pallor present, edema present, clubbing icterus cyanosis was absent, JBP was not raised. In chest finding, bilateral air entry was present, right-sided 5 inspiratory crepes were decreased. Crepes were present with decreased air entry on right lower zone. In CVS, S1, S2 was present, per abdomen slightly distended. On the basis of the complaint and physical finding, my differential diagnosis was severe pneumonia, severe anemia, postpartum sepsis, pulmonary embolism and congestive cardiac failure. In investigation, WBC was 4.2, hemoglobin 4.4, platelet was 212, MCB 83, MCS 24, RDW 16.4, viral markers was negative, LFT, KFT was normal as we can see here. Ultrasound per whole abdomen shows retained product of conception, gross POD collection, mild hepatosplenomegaly. RAT for COVID-19 was negative, chest X-ray shows right lower zone homogeneous opacity. ECG shows sinus tachycardia with right axis deviation. On the basis of above investigation and clinical finding, we ruled out postpartum sepsis and started our treatment on severe anemia with blood transfusion and pneumonia with injectable antibiotics like amoxicillin and oral macrolide and supportive oxygen therapy. Patient was put on tab mesoprostol 200 mg TDS for 3 days. In spite of above treatment, patient condition was deteriorated. Now we move one step further and applied the Wells criteria and do the clinical decision rule, in which the heart rate was more than 100, giving 1.5 point. Alternative diagnosis was less likely than pulmonary embolism, giving it 3 point. So my score was 4.5, that is more than 4. So I moved towards the diagnosis of pulmonary embolism. Further investigations were done on that line. Chest X-ray show bilateral lower lobe homogeneous opacity, D-dimer 9842 nanogram per ml, 2D echo show RA-RV dilated, thrombus size 8.88 into 9.9 mm, attached to tricuspid valve and 1 in right ventricular outflow tract. Mild circumferential pulmonary effusion was present, IVC was dilated, non-collapsible 2.16 centimeter. Moderate pulmonary artery hypertension was present with 50 plus GBP pressure. Mild TR was present, ejection fraction was 54%. Color Doppler of bilateral lower limb was normal. Double click. Okay, sure. These are the serial X-rays I have taken it. On the day of presentation, the opacity was only present on the right lower lobe. On the third day, the opacity mildly improved, and with the progression of the day, again the opacities in the bilateral lower lobe were increased. I move to a CT pulmonary angiography, central filling defect in right lower lobe, segmental branches cause complete occlusion, few central filling defect in right lower lobe, and lingular segmental and subsegmental pulmonary artery branches. Multiple pulmonary infarcts in bilateral lower moderate with moderate bilateral pleural effusion was present. So my final diagnosis was pulmonary embolism. In treatment, I give enoxaparin 0.6 ml subcutaneous BD for 10 days with antibiotic support and oxygen therapy. At the time of discharge, patient condition was improved, vitals were stable, patient was discharged on TAP apixaban 5 mg OD for 6 months. On follow-up, my patient was completely recovered. In conclusion, pulmonary embolism was, in my case, pulmonary embolism was either because of hypercoagulant state due to pregnancy or thrombus from pelvic vein, as it is most common site for thrombus formation in pregnancy. Sign and symptom, clinical feature of pulmonary embolism and severe pneumonia are same. So many times we keep on treating pneumonia and get misleaded. So I have used the term masquerading with severe pneumonia. 59% of pulmonary embolism cases remain undiagnosed during life. 7% cases are currently diagnosed with pulmonary embolism before death. 34% cases have sudden fatal pulmonary embolism. So, with proper clinical orientation and basic investigation in limited clinical setting, we can treat this final curable disease. Thank you.
So, Dr. Kumar, you feel that it has traveled through the pelvic veins?
Sir, since my bilateral lower limb color Doppler was normal, and one of the major cause was thrombus emboli from other vein. So either it was because of the thrombus dislodgement from the pelvic vein or because of hypercoagulable state because of pregnancy, sir.
So hypercoagulable state can take place anywhere?
Yes, sir.
So it is in the right atrium, that is tricuspid valve, you have got a thrombus over there.
Yes, sir.
So there are chances that further pulmonary embolism can take place?
Definitely, sir.
So what did your CT angio told afterwards? It has resolved?
Yes, sir.
First time you diagnosed by CT angio, pulmonary angio, and
yes,
it showed there is a big thrombus in the right atrium attached to the valve.
Yes, sir.
Now one incidence has taken place that the pulmonary embolism has taken place and the consolidation say differential diagnosis. Do you think that it will again have another episode of pulmonary embolism?
Definitely, sir. Previous episode of deep vein thrombosis or pulmonary embolism is the biggest predisposer for next episode, sir.
Did you get your CT done before discharge?
Definitely, sir.
And it was cleared?
Yes, sir. It was done before discharge. It was made confirmed diagnosis after that only, sir.
Okay. Very good.
Thank you, sir.
Thank you. Thank you so much. Moving ahead, I would like to request our next speaker, Dr. Piyush Ratan.
Good evening, everyone. I would like to present a case. On dengue fever, which presented as post-infective cerebralitis. My patient was a 17-year-old male who presented in a medical emergency with acute onset ataxia, incoordination, and slurring of speech for the past 12 hours. He had a history of acute febrile illness for last 5 days, for which he was taking over-the-counter antipyretic medications. The symptoms were not associated with any altered sensorium or seizure-like movement. The patient had the patient did not have any past medical or had any significant medical or family history. On examination, the vitals of the patient were stable. On neurological examination, the higher mental function, neck and spine was within normal limits. The motor system demonstrated hypotonia in both bilateral upper and lower limbs, which was more on left than right. Sensory system was within normal limits, and the patient had cerebral signs like scanning speech, ataxic gait, hypotonia, dysmetria, pendular knee jerk. Nystagmus was absent. Autonomic involvement was also absent. Rest of the system examination of the cardiovascular, respiratory, and abdomen were within normal limits. On admission, an emergent CT head was done without contrast to rule out any bleed, which showed no abnormality. Workup for fever revealed dengue, NS1 and IgM positive. CSF analysis showed normal opening pressure with mild pleocytosis. Cells were 10 per millimeter cube and with normal protein and sugar. Dengue PCR of CSF was negative. MRI brain with gadolinium contrast showed no abnormal signals within the cerebellum, CP angle, midbrain or pons. Here are the images. Management: the patient was managed conservatively with IV fluids and physiotherapy and rehabilitation therapy and was discharged on day 5 of admission. He was followed up in OPD after 20 days with no residual neurological deficit. discussion. Dengue is a mosquito-borne viral infection caused by dengue virus, and with the increasing prevalence, uncommon manifestations are often encountered, including the central nervous system involvement. Neurological complications have been reported in 0.5 to 6% of the patients, which include manifestations such as encephalopathy, seizures, permanent neurological sequelae. The postulated mechanism for CNS involvement is immunological, but is being immunological mechanism, systemic effects on the infection as well as the direct tropic effects of the virus. It is postulated that acute cerebralitis associated with viral infection can either be primary infective or can be post-infective, representing an immunological phenomena. Given the temporal profile of the patient, it is likely that our patient represents post-infective cerebralitis following dengue infection. Conclusion, dengue-related cerebralitis, although rarely reported, is a recognized neurological manifestation. Dengue cerebralitis can occur in any phase of dengue fever and is self-limiting. Thus, a patient presenting with fever and acute cerebral involvement should prompt the dengue-associated cerebralitis, especially in patients living in endemic regions. Thank you. Yes, sir.
Is dengue fever presenting as cerebralitis?
Yes, sir.
So why did you label it as cerebralitis?
Because there was involvement of cerebral, it was a case of acute cerebral ataxia, and it was post-infective.
What was in favor of inflammation of the cerebellum?
Sir, mild pleocytosis was present in the CSF.
That was because of dengue as well.
Yes, sir.
Dengue was there.
Yes, sir.
तो आपने ये टर्म क्यों चुना?
Sir.
चलो ठीक है.
Yes, sir.
So, did you give steroid in this case?
No, sir, we did not give an steroid.
The patient recovered of its own?
Yes, sir, the patient
with the treatment of dengue?
Yes, sir.
So what do you think? If a patient of cerebellar symptom comes with dengue, it is a self-limiting illness?
Yes, sir.
Okay, thank you.
Thank you, sir. Thank you, sir.
Hello. Moving ahead, I would like to request our next speaker, Dr. Anupam Ray, to please join us on the stage.
Good evening, everyone. Today I am going to present a rare case on reversible dilated cardiomyopathy in Sheehan syndrome. Sheehan syndrome is characterized by panhypopituitarism as a result of ischemic pituitary necrosis, usually due to severe postpartum hemorrhage. It manifests with lactation failure, amenorrhea, involution of breast, loss of axillary and pubic hair, and features of other pituitary hormone deficiencies. Cardiac abnormalities in patients with Sheehan syndrome are uncommon. Clinical history. A 36-year-old non-diabetic female patient with history of childbirth 2 years prior present with progressive breathlessness, effort intolerance and dependent edema over a period of 6 months. She was provisionally diagnosed a case of peripartum dilated cardiomyopathy. Standard treatment was offered and she was finally referred for further evaluation and management due to poor response to standard treatment. Clinical finding. Physical examination revealed lethargy, sparse body hair, atrophied breast, dyspnea and leg edema. Her pulse was 70 minutes per minute, regular, fair in volume, blood pressure is 90/60. Apex beat is shifted, diffuse and third heart sound is audible. Bilateral fine crackles audible in lung basis. Further inquiry revealed vaginal delivery with severe postpartum hemorrhage requiring 3 units of blood transfusion 2 years ago, followed by failure of lactation, amenorrhea and progressive effort intolerance. Investigations. Her blood counts was normal with hemoglobin 11.2 gram per dl, normal iron profile, renal and hepatic function and serum electrolytes are normal. There was cardiomegaly in her chest X-ray, ascites in abdominal ultrasound and inverted T waves in precordial lead of electrocardiogram. Echocardiography shows dilated cardiac chambers with severe global left ventricular hypokinesia, severely impaired left ventricular ejection fraction, and grade 3 mitral regurgitation. Investigation. Endocrine status reveal low thyroid stimulating hormone, low T4, low follicular stimulating hormone, low luteinizing hormone. However, her serum prolactin and ACTH level were within normal limits. Her MRI brain shows enlargement of pituitary fossa, which is filled with CSF along with thin compressed pituitary gland, shown in T1 weighted sagittal image. And her T2 weighted coronal image shows pituitary infundibulum traverses the enlarged sella to meet the thin compressed pituitary gland at the bottom, which is called infundibular sign. Treatment given. Along with diuretics, she was given AC inhibitor, digoxin, and hydrocortisone. 100 mg 6 hourly IV for 2 days, followed by prednisolone 5 mg in the morning and 2.5 mg orally in the evening. This was followed by administration of increasing dose of oral levothyroxine up to 75 microgram per day. With this treatment, the patient general well-being improved dramatically. Breathlessness decreased, edema disappeared, and psychological status improved. Her serial echocardiography over 6 months shows reduction of chamber dimension, improved myocardial contractility, and disappearance of MR. Discussion. The case presented here described dilated cardiomyopathy in 36-year-old female who failed to respond adequately to standard anti-failure treatment. All other manifestation and cardiac function reverted to normal after hormonal replace therapy. Thank you.
What happened to the posterior pituitary hormone?
Sir.
ADH.
ADH. Sir, no such symptom was present in her. Her electrolytes are normal and she was not complaining of any polyuria.
We missed doing serum ADH. ADH, antidiuretic hormone.
Yes, sir.
Posterior pituitary hormone.
Posterior ADH estimation was not done, and her serum electrolyte, serum sodium concentration is
How
also.
will you follow this case? Now proven case of postpartum hemorrhage, Sihan.
Yes, sir.
Panhypopituitarism.
Now we follow this case with serial echocardiography. Sir, we keep giving the glucocorticoid, prednisolone, 5 mg in morning and 2.5 mg in evening, followed by thyroid hormone, and continue monitoring the free T4 level for titration. Thank you, sir.
Hello. Thank you so much. There is small change in the schedule. The last 6 presentations have been transferred to Hall A. So the following people can proceed to Hall A for their presentations. Dr. Nidhi Priya, Dr. Saurav Kumar, Dr. Solanki, Dr. Shiv Kapoor, Dr. Sudhanshu Dev, and Dr. Akhilesh Kumar. All these participants are requested to proceed to Hall A for their presentations. Your presentations will be directly loaded to the laptop there only. We have already done that. Thank you. Yes, we have. Rest of the presentation will be presented here only. So the next speaker, I would like to request Dr. Rahul Raj Mishra to please join us on the dais.
Good evening, everybody. Today I'm going to present a rare case in front of you. The topic is thalamic hemorrhage-induced hemibalismus in a geriatric patient, a case report. Introduction. Hemibalismus is a relatively rare hyperkinetic involuntary movement disorder characterized by intermittent, sudden, violent, involuntary, or ballistic high-amplitude movements involving the ipsilateral arm and leg caused by dysfunction of the contralateral side. Hemibalismus falls as the most severe form within the spectrum of chorea. Chorea is an involuntary movement disorder characterized by brief, sudden, spontaneous, non-stereotyped and dance-like movements of one side of the body. Textbooks localize the lesion to the subthalamic nucleus. However, it can also be a result of lesions in other parts of the brain, such as basal ganglia and caudate nucleus, interrupting the neuronal pathways required for movement control. Pathophysiology. Hemibalismus is a consequence of damage in the basal ganglia structures involving in the inhibitory pathways. With the decreased excitatory transmission of the globus pallidus internus and the disinhibition of the thalamus, it creates an overactivation of the corticospinal and the corticobulbar tracts with random firing. To better understand the pathophysiology of hemibalismus, a review of the complex basal ganglia inhibitory and excitatory pathway is mandatory. Pathophysiology. As you can see from the diagram, the cortex input is sent to the basal ganglia with a subsequent output directly to the motor neurons in the frontal lobe and brainstem, leading to planned activation or inhibition of the movement. The fibers from the globus pallidus convert into a white matter tract called the lenticular fasciculus that forms the bundle called the thalamic fasciculus as it enters the thalamus. Thalamus itself is an important relay of excitatory signals to the motor cortex and somatosensory signals coming from the body. Strokes causing hemichorea hemibalismus syndrome usually localizes to lesions occurring in regions functionally connected to the motor output from the brainstem and thalamus. Now let's take a look at the different type of pathways. First is excitatory pathway, which starts with the excitatory glutamate-driven input from the cortex to the corpus striatum, that is caudate nucleus and putamen. The activation of the striatum sends D1 dopamine receptor-driven inhibitory GABAergic signals to the globus pallidus internus. The inactivation of the globus pallidus internus allows excitatory glutamate signals to be generated in the thalamus, which is also called the disinhibition of the thalamus. Relaying fibers to multiple areas of the motor cortex, which upon activation leads to downstream activation of corticospinal and bulbar tracts, hence generating movement. In the inhibitory pathway, it starts in the cortex, the activation of D2 dopamine receptor leading to firing of the globus pallidus externus, which sends its signals to the subthalamic nucleus, which then activates the GPI, that is globus pallidus internus, which puts inhibition on the thalamus, leading to decreased activation of the cortex and subsequent blunting of the tract. Etiology. Following are some of the common etiologies of hemibalismus, which includes intracranial hemorrhage, ischemic stroke, which is the most common cause of patients more than 65-year-old, neoplasm, head trauma, metabolic, which is non-ketotic hyperglycemic hyperosmolar syndrome, tuberculomas, toxoplasmosis, neuroinflammatory disease, and toxins such as alcohols and heavy metal exposure. Now I present to you a case report of 71-year-old female who presented with complaints of sudden onset violent, jerky, involuntary movement of right side of the body associated with difficulty to perform normal tasks and agitation for 3 days. The hemibalismus was significant and persistent, resulting in profound functional disability. There was no history of headache, vomiting, or any other focal neurological deficits. She had a history of hypertension since 5 years, but not on any medication and was poorly controlled, and no history of any other comorbidities. General examination was normal. Blood pressure was increased, which was 150/90. Heart rate was 92 beats per minute, and the patient was in the anxious state. Neurological examination had balismus of the upper and lower limb associated with hypertonia and extensor plantar on the right side. There was no sensory motor involvement. The movement used to stop while sleeping and start again as the patient woke up. The movement were enhanced with heightened emotional states. Investigations, all the routine investigations were normal. A brain CT was performed, which shows a 9/8 millimeter size nodular hyperdense lesion with focal perifocal edema involving left thalamus, suggestive of acute small hemorrhagic infarct. Cerebral MRI revealed nodular blooming in the left thalamus with subtle surrounding hyperintensity, which was suggestive of left thalamic hemorrhagic infarct with microbleeds and small vessel disease. Treatment, the patient was prescribed the following treatment: tablet haloperidol 1.5 mg, 1 tablet thrice daily, tablet clonazepam 0.25 mg, tablet tetrabenazine 25 mg, half tablet injection valproic acid, and physiotherapy and rehabilitation. Discussion. Cerebrovascular accidents often present with negative symptoms such as weakness with reduced movements of body parts or sensory loss. In conclusion, the rarity of thalamic-induced hemibalismus accentuates the significance of this case, urging a better understanding of the diverse neurological sequelae associated with thalamic pathology in the adult population. Thank you.
This hemibalismus is abnormal jerky movements.
Yes.
Okay. And you found it in thalamic hemorrhage. So apart from this, keep it aside. What are the other abnormal movements which you can describe. Other abnormal movements.
Other abnormal movements include dystonia, Parkinsonism, myoclonus, and chorea.
Can you rectify again? Chorea को रख लो, आगे बोलो.
Myoclonus, dystonia, Parkinsonism, tics, and myoclonus.
Acetosis.
Chorioathetosis. Chorioathetosis. Yes, sir.
Will be there.
Yes.
Just give only one definition. Chorea. What is chorea? Define.
Sir, chorea is a rapid, jerky movement, but which has a certain flow to it and which does not affect day-to-day functions of the patient.
Okay. Thank you.
Thank you, sir.
Thank you so much. I would like to request our next speaker, Dr. Nitish Kumar, to please join us on the stage.
Hello, I am going to present a topic, my paper on the topic gut microbiota dysbiosis in inflammatory bowel disease, insights, implications, and the therapeutic perspectives. Main aims are to provide a comprehensive overview to highlight mechanistic insights and clinical implications of the gut dysbiosis, identification of dysbiotic signatures or NICs, and evaluation of therapeutic perspectives of gut dysbiosis. For this, we conducted a systemic search of scientific databases of mainly the comprising of meta-analysis cohorts and the experimental research investigations. Now discussion insights on gut dysbiosis in inflammatory bowel disease is mainly because of three factors. First is the microbial imbalance. Microbial imbalance can be of two varieties. One is the reduced diversity, or other is the altered bacterial composition. In reduced diversity, often it's seen in IBD patients that there is decreased microbial diversity in gut compared to the healthy individuals. In altered bacterial composition, we see that there decrease in beneficial bacteria such as like Faecalibacterium and Bifidobacterium, and increase in potentially harmful bacteria like certain bacteria demonstrated such as Escherichia coli and Fusobacterium. Also associated is metabolic dysfunction. Dysbiosis affects the metabolic functions which affect the nutrient absorption and microbial metabolite production. Because gut microbes, they ferment dietary fibers to produce short-chain fatty acids like acetate, propionate, and butyrate. These short-chain fatty acids are crucial for maintaining gut health, modulating and immune responses, and providing energy source for colonocytes. Butyrate in particular has anti-inflammatory effects, and they also regulate the immune responses. So dysbiosis-related changes in short-chain fatty acid production can impact the local immune regulation. Other implications of the gut dysbiosis is the immune dysregulation. Dysbiosis may disrupt the balance between pro-inflammatory and anti-inflammatory signals in the gut, leading to loss of immune tolerance towards gut microbiota. And dysbiosis-induced inflammation involves the release of certain inflammatory cytokines such as TNF-alpha, interleukin-6 and interleukin-18, contributing to tissue damage and perpetuating the inflammatory cycle. They also can lead to mucosal barrier dysfunction such as and cause leaky gut and bacterial translocation. So, in short, we can say that dysbiosis is implicated in onset, pathogenesis, and exacerbation of symptoms, and also correlate with severity and progression of IBD. Now, coming to the last part, therapeutic perspectives of gut dysbiosis in IBD. Certain therapeutic approaches targeting dysbiosis may help to restore the healthier gut microbial balance, which helps to alleviate symptoms and potentially modify the disease course. And here are some key therapeutic perspectives. First is the probiotics and prebiotics. Probiotics are live microgerms that when administered in adequate amounts confer health benefits. Prebiotics are dietary compounds that promote the growth and activity of beneficial gut bacteria. Another therapeutic perspective is fecal microbiota transplantation, that is transfer of healthy microbiota from fecal material, healthy fecal material from healthy donor to a recipient with aim of restoring a healthy gut microbiota. Other are the microbiota targeted drugs, so that we can develop drugs that specifically target the dysbiotic microbial populations. Next is the dietary intervention, in which we focus on certain diets such as low FODMAP diet, and antibiotics. In some antibiotics might be used in certain cases of IBD to target special bacterial overgrowth. personalized treatment can be used if we study an individual's unique gut microbiota profile to guide personalized treatment strategies. Also, we can focus on lifestyle modifications. And results, this review highlights substantial alterations in the gut microbial composition characterized by the decreased abundance of commensal bacteria and enrichment of potentially pathogenic species in individuals with IBD. And now, finally, coming to conclusions, gut microbiota dysbiosis represents a hallmark feature in the pathogenesis of IBD, implicating a bidirectional relationship between microbial alterations and disease activity. Strategies targeting the restoration of a balanced gut microbiome, such as precision microbiome-based therapeutics and personalized dietary interventions, hold promise in modulating disease progression and improving treatment outcomes in IBD. However, further investigations into the intricate mechanisms underlying dysbiosis and well-controlled clinical trials are imperative to validate the efficacy and safety of microbiota-targeted interventions for IBD management. Thank you.
So, two major diseases of inflammatory bowel disease. Number one is Crohn's disease and ulcerative colitis. Is it? Where it stands? Your gut microbes stands where? Therapy with microbes, probiotic and prebiotic, where it stands. You have got other drugs. Can you name some of the drugs which are used in inflammatory bowel disease?
ASA derivatives, local corticosteroids, oral or rectal steroids, mainly steroids, and then biological compounds like compounds focusing on TNF-alpha inhibitors like infliximab, certolizumab, and other biological, mainly biologicals and steroids and ASA derivatives.
First is 5-aminosalicylic acid, mesalamine.
Mesalamine, sulfasalazine.
Before that was sulfasalazine.
Sulfasalazine, yes.
And then comes steroid.
Yes, sir.
Steroid in limited number of cases. Where does this stand, your drug?
They help in modifying the, it starts with the pathogenesis
part. Adjuvant?
Adjuvant, kind of adjuvant. Supporting therapy. Not the alone therapy. We can use it to modify the therapy, not alone therapy.
Okay.
Thank you so much. I would like to request our next speaker, Dr. Anand Kumar, to please join us on the dais.
Good evening, everyone. Today I am going to present a rare case of subacute sclerosing panencephalitis. Introduction. Subacute sclerosing panencephalitis is a slow, irreversible, neurodegenerative sequelae of the hypermutated wild measles virus infection. Children under the age of 1 year have a high risk of getting disease when compared to the adults. The risk of acquiring SSP is increased if the onset of the measles is preferably at younger age, in lower socioeconomic class, poor immunity status, and overcrowding. The clinical characteristic of the disease is marked The clinical characteristic of the disease is marked by the behavioral changes, focal or the generalized seizure, ataxia, which might progress to a persistent vegetative state. The mortality rate of SSP is 95% and most of the patients survive only 1 to 3 years after diagnosis. The global prevalence of SSP has diminished to a less than 70 per 1 lakh case due to the robust immunization coverage. Case presentation. A 20-year-old female with low socioeconomic status present to an emergency department with high-grade fever, chills, and altered sensorium. Her relatives give a history of severe bilateral proximal myoclonic jerk followed by a generalized tonic-clonic seizure on the day of admission. She had a history of recurrent episode for past 3 years, which was progressive decline in cognition. She had no sign of cranial nerve involvement and her vision as well as eye movement were normal. The patient had history of measles in childhood with doubtful measles vaccination status and an unremarkable family history. On clinical examination reveals a disoriented patient with severe disabilities and a GCS score of 6/15, and the neurological examination depicted an increased tone of bilateral upper and lower limb, and the motor reflexes are normal. Investigation. complete blood count, serum electrolyte, and urine within the normal limit. On CSF examination, fluid study depicted normal level of glucose, protein, and WBC. The CSF measle IgG antibody and serum measle IgG titer were elevated. The MRI had normal signal intensity with no evidence of abnormal enhancement in any region of the brain. The EEG show periodic wave of complex composed of slow wave with high amplitude. These waves were repeated seen every 4 to 10 seconds. Therefore, a diagnosis of subacute sclerosing panencephalitis was made, and the patient was managed with anti-epileptic drugs and other supportive treatments.
Which proved it to be the sequelae of measles was serum measle IgG positive. Suppose ये positive नहीं होता, तब आपका diagnosis क्या होता?
Sir, in EEG, the waves slow. The EEG show the slow wave with high amplitude and repeated every 4 to 5 seconds. And the MRI finding is not in this case, but in MRI there is the hyper enhanced lesion in frontal or.
इसको इस तरह लीजिए. What should be your differential diagnosis in this case?
Differential diagnosis.
What do you think? Cerebral palsy.
Yes, sir.
Patient could walk in this case?
No, he was not walk. GCS is very poor.
आपके फेवर में सिर्फ वही IgG measles का जो है ना,
जी सर,
वही आपके फेवर में,
जी सर.
And your diagnosis is almost correct.
जी सर.
Thank you.
Thank you, sir.
Hello. Moving ahead, I would like to call our next speaker, Dr. Piyush Kumar. After Piyush Kumar, we have Dr. Ravi Shankar. After that, we have Dr. Samik Ahmed, Dr. Zishan Ali Khan, and Dr. Hilal Khan.
Good evening, everyone. Today I am going to present a case report on dermatomyositis. ये आगे कैसे बढ़ेगा स्लाइड? दिस बटन is next to Introduction. Dermatomyositis is classified under idiopathic inflammatory myositis. Dermatomyositis is acquired immune-mediated muscle disease characterized by symmetrical muscle weakness and skin rashes. It can also involve other organ systems like gastrointestinal, pulmonary, and cardiovascular system. Case report. A 40-year-old female came to DMCH emergency with complaint of skin lesion over dorsum of hand, neck, back, and over eyelid for 7 months, difficulty in climbing upstairs, lifting the arm overhead, and weakness for 4 months. The patient also has complaint of difficulty in swallowing. There was no any significant past history. General examination. Her vitals were stable, pallor was present. There was no icterus, clubbing, edema, lymphadenopathy. Skin manifestation revealed heliotrope rash, Gottland papule, Sol sign over back, V sign over neck, poiquiliodermatous skin changes were present over face and chest. Other system examination revealed no abnormality. Lab and radiological report. Her hemoglobin was 5 gram per dl. SGPT, SGOT value was mildly raised. CPK value was greater than 900 and her ANA was positive. Her serum thyroid profile and CA125 level was within normal range. Her HRCT chest revealed solitary pulmonary nodule of size 29 into 42 into 36 mm and multiple necrotic lymph node in pre and paratracheal region, likely of neoplastic etiology. Treatment. The patient was managed using tablet prednisolone 50 mg oral daily, tablet methotrexate 10 mg once weekly, tablet folic acid 5 mg and other supportive treatment. Discussion. Dermatomyositis has bimodal peak of distribution with greater female preponderance. Juvenile dermatomyositis is the onset of dermatomyositis between age 15 to 15 years. The 5 to 15 years. The subset of dermatomyositis where the skin manifestation may be the only clinical sign of dermatomyositis is known as amyopathic dermatomyositis. Dermatomyositis has been linked with increased risk of malignancy, with breast, lung, ovary, colon and bladder involvement having higher incidence among the malignancy. Cancer-associated dermatomyositis is often used to classify patients with dermatomyositis with detected cancer within 3 years before or after dermatomyositis diagnosis. Although the time span between the malignancy and dermatomyositis varies between the studies. Thank you.
When the person came first to you, she had skin lesion?
Yes, sir.
And the muscle lesion?
Yes, sir. Muscle, skin
so
lesion.
your first diagnosis was dermatomyositis?
No. Her thyroid reports were normal. Her RA factor anti-CCP were normal. Every reports were normal. Then she was complaining of a proximal weakness, and there was skin lesion. So we gave CPK, and it was raised. So we gave then screening for screening for malignancy, and had HRCT chest.
Tell one differential diagnosis of dermatomyositis. One, only one.
Drug-induced myopathy, or
दोनों ना है.
Yes.
दोनों ना है आपको, स्किन भी है, मसल भी है.
अच्छा.
तो बताइए.
ड्रग इंड्यूस हो सकता है, फिर facioscapular humeral dystrophy and all.
Did you take a consultation from skin also?
Yeah.
And they also proved it to be.
Yes.
Okay, go. Thank you.
Hello. Hello. Dr. Ravi Shankar, according to the schedule that I have in hand, he's the last speaker. But I would just like to go through once all the names, if anyone is missed by, unfortunately. Dr. Kundan Kumar from Bhagalpur. Dr. Shubham Kumar Sanghai. If anyone is present, please let us know. Dr. Shruti Rich, sorry. Dr. Mangilal.
Good morning to all of you. I'm going to present a case report on overlap syndrome. ये क्या होगा? अच्छा ये वाला ना, ठीक. Overlap syndrome is a syndrome complex that may but need not meet complete diagnostic criteria for any one of the classic systemic rheumatic disease. As much as 1/4 of the systemic rheumatic diseases can't be definitely diagnosed, they remain undiagnosed during later years of follow-up. Earlier, these cases were described as having collagen or connective tissue diseases since they share similar clinical and pathological features of widespread inflammation. Now, systemic rheumatic disease has replaced collagen or connective tissue disease. This change reflects the recognition that these disorders probably represent the perturbations of the immune system with resultant inflammatory tissue injury rather than primary disorders of collagen or connective tissues. My case was 16 years old Muslim female student resident of Madhubani came to OPD on 6th of Feb 2023 with complaints of wounds in multiple toes of both legs for 15 days, multiple joints pain for 1 month, generalized body ache for 1 month. She gave history of recurrent episodes of discoloration of fingers and toes which resolved on warming the hands and feet often. Also, these episodes frequency increased during cold weather. Multiple wounds appeared on multiple toes since last episode of discoloration of digits which were painful, and some toes have gangrenous autoamputation of distal parts. Joint pain was also symmetrical, involving both large and small joints with no restriction in range of movement and associated with morning stiffness. Patient was non-diabetic, normotensive, non-smoker, non-alcoholic. Her vitals were stable with pulse rate was 94 per minute, regular fair in volume, soft and compressible arterial wall, and all peripheral pulses were felt. She had moderate pallor present. Her respiratory system was within normal limits. There were vesicular breath sounds heard all over the areas of auscultation with no added sounds. There was no Gottman papules, malar or discoid rash, heliotrope rash, thickening of skin, especially around face. There was no sclerodactyly, recurrent oral ulcers, calcinosis cutis seen. Her complete hemogram findings were within normal limits except moderate anemia. Her ESR was 42 millimeters in first hour. Her RFT and LFT were within normal limits with serum TSH was also 1.2 microunits per ml, which rule out any other concurrent autoimmune thyroid disorder. Then we ordered ENA panel where anti-dsDNA, Rho antibody, SCL70 and Smith antibody were significantly positive. Then ANA immunofrequency SI was done where ANA was positive and the pattern was nuclear and it was homogeneous and intensity was 3+. Diagnosis: this case has secondary Raynaud's phenomena with gangrenous autoamputation of digits with bilateral symmetrical large and small joints, inflammatory bowel arthritis with no bony erosions, and in ENA panel there is sufficient evidence of multiple systemic rheumatic disease activity, namely progressive systemic sclerosis with SLE. Hence this is a case of overlap syndrome. Surgeon's opinion was taken for gangrene. Steroids at the rate of 1 mg per kg per day was started. Hydroxychloroquine 200 mg BD was given. Amlodipine 5 mg OD was given. Calcium supplementation was given, and the patient was referred to Department of Rheumatology for further management. If 1/4 cases of rheumatic disease present with a clinical and or biochemical overlap of 2 or more classic rheumatic disease, then keeping overlap syndrome as a differential is must, as treating the major clinical entity may lead to worsening prognosis due to inadequate suppression of the activity of non-major classic rheumatic disease. Currently, the patient has no documented evidence of cardiac, renal and respiratory system involvement, so treatment was kept conservative and the patient was kept on regular follow-up to ensure desired favorable outcomes and course.
What made you to think it is an overlap syndrome?
Sir, there was...
Minus your biochemical examination. Minus. Yes. Tell me the clinical findings.
The sir, patient was having Raynaud's phenomena, secondary Raynaud's phenomena. But there was no, and there was joint involvement. Joint involvement which was inflammatory in type with Raynaud's phenomena. It gives... Sir, yes. Sir, generally if we suspect rheumatic involvement, then we usually go for, sir, a serum ANA And if it's positive, then we go for ENA profile. Then we found
जो ड्रॉ कर पाए आपके इससे कि the person who comes with either of the two diseases, we should keep this in mind. There might be overlap syndrome, isn't it?
Yes.
Thank you.
Thank you.
Hello. I would like to request our next speaker, Dr. Sameek Ahmed, to please join us on the dais.
Good evening, sir. Myself, Dr. Sameek Ahmed. Today my topic is prognostic importance of hyponatremia in acute ST elevation MI in tertiary care center. Next case. Next. Cardiovascular disease accounts for approximately 17.8 million deaths annually and to the common cause of death globally. Acute myocardial infarction continues to be a major public health problem in the developing countries like India. Death rates of coronary artery disease are 3 times more than that of a stroke. Hyponatremia, a commonly occurring electrolyte deficiency found in inpatient department, more especially in cardiac care unit, in surgical post-operative ward, and in patients with cardiac failure. In patients with heart failure, hyponatremia has been shown to be predictor of cardiovascular mortality. Neurohormonal activation that occurs in acute MI is similar to that which occurs in heart failure. Hyponatremia happens frequently after MI, and clinical improvement happens by rise in plasma sodium concentration. My aim and objective is to investigate the prognostic importance of hyponatremia in acute ST elevation MI and to determine its usefulness in predicting short-term survival. Materials and method. This is a prospective observational study of 100 patients presenting with acute ST elevation MI admitted in medicine ward KMCH Katihar. This study was approved by the Institution Ethical Committee and informed written consent was taken from the patient, and then it was conducted. Detailed history and clinical examination has been done. Plasma sodium concentration were taken on admission at 20, 48 and 72 hours thereafter. The primary endpoint has been taken as mortality within 30 days following myocardial infarction. Inclusion criteria. All patients of chest pain diagnosed as ST elevation MI presented to KMCH, individual age with 30 to 85 years, chest discomfort or pain occur more than 20 minutes with definitive BCG changes, ST elevation more than 1 mm in more than 2 contagious limb lead, and ST elevation more than 2 mm in more than 2 contagious precordial lead. Exclusion criteria. All patients diagnosed as acute cardiac event other than ST elevation MI, individual age less than 30 years and more than 85 years. Result. The maximum number of patients were in the age group of 51 to 60 years, followed by the age group of 61 to 70 years. Normal sodium level patient number is 71, and hyponatremia on admission is 11. Hyponatremia within 72 hours occur in 18 patients. Patient presenting with hyponatremia on admission had high percentage of death when compared to patient presenting with hyponatremia after 72 hours. Severity of hyponatremia correlated well with mortality. Total 3 patients had sodium level less than 130 millimole per liter, and all the 3 died when compared to 3 deaths among 26 patients with sodium level between 131 to 134. In this study, hyponatremia was present on admission in 11 patients and developed in 18 patients during the first 72 hours. A total of 8 deaths occurred within 30 days of admission. In this study, we found a trend of increasing mortality with the severity of hyponatremia. This was in concordance with the study conducted by Goldberg et al., who showed increasing mortality with severity of hyponatremia. Conclusion. In our study, we concluded that hyponatremia on admission or early development of hyponatremia in patients with acute ST elevation MI is an independent predictor of 30 days mortality. Plasma sodium levels may serve as simple marker to identify patient as risk. Thank you, sir.
A young patient
yes,
with no previous history of any disease, any ailment, suddenly gets acute ST elevation MI. ठीक है? Now he comes to you. तो उस पेशेंट में हाइपोनेट्रीमिया कैसे होगा ये बताइए, तब ना ट्रीट कीजिएगा.
Sir, over activation of RAS.
ओवर एक्टिवेशन ऑफ रास, तो उससे क्या होगा?
सर उससे वाटर का रिटेंशन होगा, जिससे
तब फिर आपको हाइपोनेट्रीमिया के कॉज में जाना पड़ेगा। डाइल्यूशनल है
Yes,
या इनटेक कम है
Yes,
या SIADH है, वो अलग बात हुई।
Yes,
एक कारण बताइए, रास हुआ
यस सर,
तो वाटर एब्जॉर्ब हुआ,
यस सर,
है ना?
AB
एक्टिवेशन ऑफ
ABP
रेनिन एंजियोटेंसिन एल्डोस्टेरॉन एक्सिस
Yes,
या सिस्टम,
यस सर,
तो उसके द्वारा आपका पानी एब्जॉर्ब हो गया और जो सोडियम है उसका कंसंट्रेशन कम हो गया।
यस सर, वेसोप्रेसिन
तो टेक होम मैसेज इसमें ये है कि इफ अ पर्सन ऑफ स्टेमी कम्स, we routinely should do serum sodium and see if there is hyponatremia due to any cause. We
Yes.
have to treat it so that the 30 days mortality should come down.
Yes.
Isn't it?
Yes, sir.
Okay. Thank you.
Thank you so much. I would like to request our next speaker, Dr. Zishan Ali Khan, to please join us on the dais. This is the second last talk of the day.
Good evening, sir. My topic is study of thyroid profile in patients of type 2 diabetes mellitus. Introduction. Diabetes mellitus is a common endocrine disorder which involves multiple organ systems and leads to the significant morbidity and mortality due to accompanying complications. Diabetes mellitus has been defined as a metabolic syndrome characterized by chronic hyperglycemia and disturbance of carbohydrate, fat and protein metabolism associated with absolute or relative deficiency in insulin secretion or insulin action. Thyroid hormone plays an indispensable role in various metabolic processes in our body. Excess or deficiency of the either insulin or thyroid hormone can result in the functional abnormalities of one another. Though it has been since long recognized that diabetes and thyroid disorders shares a complex interplay of factors, the present study is the plan to study the thyroid profile in patients of type 2 diabetes mellitus. Aims and objective. To study the prevalence of thyroid disorder in patients with type 2 diabetes mellitus and to study the distribution of thyroid disorder in patients of type 2 diabetes mellitus regarding age, sex, duration of diabetes, family history, regularity of treatment and BMI. Material. 100 diabetic patients were admitted in KMCH medicine department is the subject of this study. The study was approved by the institutional ethical committee and written informed consent was obtained. To study the thyroid profile in patients of type 2 diabetes, our study type is observational and single center. BMI calculation, blood pressure, fasting blood sugar, PPBS, blood urea, serum creat, ECG, thyroid profile has been done in all the patients included in this study. Inclusion criteria, known type 2 diabetes mellitus subjects who gave informed consent to participate in the study. Exclusion criteria is patient not willing for study, patient with known thyroid disease, patient with CKD or diabetic nephropathy, patient with acute illness, patient with hepatic dysfunction, patient with psychiatric illness. Result, it was found that only 61% of the patient with diabetes were euthyroid. Amongst the patient with thyroid disorder, hypothyroidism was more prevalent than hyperthyroidism, that is 31% and 10% respectively. On further assessment with respect to the primary and subclinical hypothyroid disorder, it was found that subclinical hypothyroidism was more common as compared to the primary hypothyroidism. Subclinical hypothyroidism was more common than hyperthyroidism in patients with type 2 diabetes. Conclusion. The study concluded that the screening of thyroid dysfunction among the patient with type 2 diabetes mellitus should be routinely performed to recognize the dysfunction early. This will ensure timely therapeutic intervention and in turn will improve the management of both disease, leading to the better quality of life and decrease the burden of complications. Thank you.
So, your presentation is that 31% of these patients will have hypothyroidism.
Yes.
Right?
Yes.
One precaution you should speak in relation to your topic diabetes and hypothyroidism. One.
Precautions.
आपके पास डायबिटीज भी है और हाइपोथायराइड भी है, क्या करिएगा क्या नहीं करिएगा जो ये स्टेबल रहे?
control of.
क्योंकि ध्यान रखिए, if you treat hypothyroidism with LT4, is it going to make some difference in diabetes? Both autoimmune relation is there, no doubt. So you have to be very careful treating hypothyroidism in relation to diabetes. अगर आप इसको एक्सेस ट्रीट कर दीजिएगा तो ये आपका गड़बड़ा जाएगा.
Yes.
बात समझ रहे हैं?
Yes.
So you have, once you have taken up this subject, you have to keep in your mind that in future if both the condition comes together,
yes,
you have to be very careful in treatment. Okay?
Yes.
Thank you.
Thank you, sir.
Thank you so much. Last but not the least, our last speaker of the day, Dr. Hilal Ahmed Khan.
Good evening, everyone. My topic is the study of non-alcoholic fatty liver disease in type 2 diabetes. Introduction. Spectrum of liver disease ranging from innocuous enzyme elevation to progressive chronic liver disease has been described in association with type 2 diabetes mellitus. Chronic elevation of transaminases often reflects underlying insulin resistance. Non-alcoholic fatty liver disease is a liver condition that is being recognized with increasing frequency, and it may progress to end-stage liver disease. NFLD can affect any age group. The presence of type 2 diabetes significantly increases the risk and severity of NFLD. Among type 2 diabetes, almost 50% of patients have fatty liver. Prevalence of NFLD in type 2 diabetes mellitus has not been well studied, and there is epidemic rise in type 2 diabetes mellitus. Its association with CLD, chronic liver disease in the form of NFLD, makes it important health problem. The present study was undertaken to study NFLD in type 2 diabetes. The study aims and objectives: to study the prevalence of non-alcoholic fatty liver disease in type 2 diabetic patients, to study the correlation between glycemic level and duration of diabetes with ALT levels. Material: type 2 diabetic mellitus patient attending medical outpatient department at KMCH Hospital, Katihar, were taken for the study after considering the inclusion and exclusion criteria. Informed consent were taken from each patient included in the study, and this study is approved by the Institution Ethics Committee. These patients were evaluated by abdominal ultrasonography to determine the presence of fatty liver. All patients were further evaluated by measurement of body mass index, central obesity, HbA1c and lipid profile. Inclusion and exclusion criteria are: inclusion criteria, known case of type 2 diabetes mellitus, 1 year prior to study diagnosed as per WHO criteria. Exclusion criteria: those who were with the history of alcohol consumption, use of drug causing LFT abnormality and HbA1c positive were excluded. Results: out of 100 diabetic patients enrolled in this study, 64% presented with NFLD. The highest prevalence of NFLD was recorded in the age group of 50 to 59 years at 37.5%. The prevalence rate among males was 65.62%, was higher than for the females, 34.38%. A compromised NFLD patient 64% and non-NFLD patient 34%. Conclusion: this study revealed that NFLD is a vital part of a cluster of abnormalities such as dysglycemia, dyslipidemia, hypertension and obesity. Age and duration of diabetes are also important contributing factors in occurrence of NFLD. Thank you.
NFLD, now prevalent, diabetes, non-diabetic. Can you tell us some Indian drug which is given for NAFLD?
Sir, PPR
Indian research, prove one. If I ask you what is the treatment of, maybe set aside diabetes, isolated NAFLD, then what will you tell?
Isolated NAFLD?
Yes, a person is having NAFLD. Come on.
Sir, PPR,
non-alcoholic fatty liver disease is primarily diagnosed on ultrasound. Go further, you go for fibroscan. Let it be only ultrascan. The radiologist say fatty liver 2. Now you have to treat.
Sir, PPR alpha plus beta, alpha plus gamma agonist are used, sir. Pioglitazone.
ठीक है, पायोग्लिटाजोन भी है, उससे अच्छी दवा बताइए.
सर वो Linaglip, Saroglitazar.
Yes. How much is the dose?
4 mg, sir. 4 mg, 8
How
mg.
long?
So for 3 months minimum, we should start and this taper.
कब तक देंगे?
सर नहीं.
26 हफ्ते. और घुमाइए 45 मिनट को घुमाइए.
हाँ तो वेट रिडक्शन एंड डाइट मॉडिफिकेशन इनिशियल में वही करेंगे.
हाँ. मेटफॉर्मिन भी है. जी. मेटफॉर्मिन भी है. पायोग्लिटाजिन, सारोग्लिटाजिन इज द इंडियन रिसर्च फ्रॉम Cadila 4 milligram. Proven. 26 weeks you give, the patient will recover with the prohibition of everything. Thank you.
Thank you so much. With this, I would like to announce that we are done with the free papers for the day. Thanks to our judges and thanks to all people who stayed back till last free paper presentation. Thank you all for patient hearing. And with this, we are concluding with the day 1 of this particular hall, Hall B, for our 33rd BAPICON and 2nd EZAPICON here at Bhagalpur. Thank you so much. And this is your MOC Rituja Kohale from Team Nikhil Khatri signing off. Thank you.